So welcome to our attendees and my colleagues and faculty joining us today. I'm Scott Tykodi. Many of you, I'm sure I know from clinic, but I'm a physician here at the Fred Hutch campus in the University of Washington. I'm a clinical provider. I see kidney cancer patients in our clinic. I do clinical research on campus. I do translational work with colleagues that run a wet lab program for kidney cancer. So this is what I do every day, and I'm delighted to have a chance to share with my colleagues some thoughts and perspectives on kidney cancer over this morning's program. Ritu, can I have the next slide, please? So this is what our agenda looks like for the day. We'll have 2 hours of information. We'll take a short break at the 11 o'clock hour, and then we'll come back and we'll finish the program and shoot to be done by 1 p.m. Next slide, please. So just a couple of housekeeping items before we jump in and get going. We are recording the event, which means it'll be curated and ultimately posted on our web pages. And so if you have to sign off, if you miss any information or want to come back to it and see it again, it will be posted on the Fred Hutch website a couple of weeks after the program. If you have questions, we'll try and have a little bit of time after each of the speakers where we can respond to questions that are posted in the chat. So we'll keep an eye on the chat as we go. If you accidentally drop out of the Zoom call, you can follow the link and come back in. And as I say, the items will be posted and recorded. And I will prompt you now, but we'll also remind you at the end to please fill out the feedback form. Dr. Gore and I do review that after the session. We're always interested in people's perspectives on the virtual platform versus veering back towards an in-person program, things that you like, things you didn't like, topics that you're hoping to see on future programs. And we do try and react to that and try and pull in things that people are pointing out that they would find interesting. And so with that, let me turn it over to my colleague, Dr. Gore, for his own introductions before we get into the program. John?
Hi, good morning, everyone. I just want to echo Dr. Tykodi and welcome everybody to our annual symposium. It's wonderful to see so many people on the Zoom. Dr. Tykodi and I have co-chaired this for several years. My role in our kidney cancer program is as a surgeon and urologist. And so most of my practice is managing kidney cancer through surgical solutions. And I'm really looking forward to a wonderful symposium today. So thank you, everyone, for being here.
Well, thank you, John. So I'm delighted. Our first speaker in a keynote length talking slot is an outside investigator, Dr. David Braun, that's currently at the Yale School of Medicine. So let me just give you a few comments about Dr. Braun for those who may not be familiar. David's training goes back to New York City, where he did an MD as well as a PhD training program.
I just figured it out.
At the Icahn School of Medicine of Mount Sinai in New York City, but also a PhD in computational biology from New York University. And on completing those programs, he then did his internal medicine residency training at the Harvard Medical School and Brigham and Women's Hospital program in Boston. Stayed in Boston for medical oncology fellowship at the Harvard Medical School and Dana-Farber program, and stayed on after end of fellowship as an instructor working with faculty there that many of you, I'm sure, can easily recognize: Tony Schwery, Catherine Wu, published a number of impactful papers and received many awards I don't have time to list off. But then in 2022, David moved on to the Yale School of Medicine, where he's now assistant professor in the Department of Medicine and Medical Oncology and a member of their Cancer Immunology Research Program. He runs his own research lab program on their campus. And so I'm thrilled to have him join us today. The title of his talk this morning is Current and Emerging Treatment Options for Advanced Kidney Cancer, a focus on immunotherapy. David.
Thank you so much for the very kind introduction, and of course for the invitation to speak. This is such an important event to get to interact with patients directly, to hopefully provide some helpful information but also be able to answer any questions you might have. And so I'm going to bring up my slides here. The first thing I'll do is just check to make sure that they are projecting okay. Can you see that okay?
Perfect.
Yeah, that's perfect.
Perfect. So what I want to talk about today is kind of a whirlwind tour of immunotherapy in kidney cancer. And I'll try to get a little bit about the why I think immunotherapy is so critical for kidney cancer, how it's really, I think, transformed the way we treat advanced kidney cancer, particularly clear cell histology, which is what we know the most about. But in order to do that, I do want to give a little bit of history, a little bit of a historical perspective on why I think this is important. But two, we have so many therapies available, but also so many that are emerging, so many clinical trials in different spaces. And so I also want to try to provide a kind of a simple framework for how to think about all these different immune therapies that ultimately might be used for the treatment of kidney cancer. And so to begin, I do want to go a little bit far back and sort of introduce the notion that kidney cancer has this long-standing reputation of being a type of cancer that the immune system might, in certain circumstances, be able to recognize and even effectively get rid of. And there are isolated reports, not large-scale data, but isolated reports that go back well over 100 years. And I thought it'd be helpful to sort of highlight a few of those. One goes back to 1917. This is from Charles H. Mayo, a surgeon, actually one of the surgeons who co-founded the Mayo Clinic, and published a report of how after removal of a kidney tumor on the left kidney, that what looked like metastatic disease, advanced disease in the lung, seemed to regress. Again, hinting that some sort of immune perturbations, in this case surgery, might lead to regression elsewhere. It's not just surgery that might have this effect. So these isolated reports over time of even radiation having this effect. This is back before it was called renal cell carcinoma and was referred to as hypernephroma. But when one spot got zapped with radiation, other spots might have disappeared, the so-called abscopal effect. Incredibly rare. This is far from the standard, but again, these isolated pieces of evidence that kidney cancer really might be a type of cancer that might respond to the immune system. And then even in our current era, this is, again, just an anecdote, but isolated case reports of people, even with a COVID infection, who subsequently had regression of their kidney cancer. Again, this idea that if the immune system is stimulated, whether that's by the medicines we use, whether that's in these rare cases by surgery or radiation or even infection, that active immune system might be able to effectively attack and even clear some kidney cancer. And so these are all kind of anecdotes, but where does the data lie? What's the sort of historical evidence for immunotherapy being important for kidney cancer? And to look at that, I really want to sort of take a step through the last couple of decades in kidney cancer therapy before we dive into how to think about it moving forward. And so going back 25, 30 years, really the mainstay of therapy was cytokine-based therapy. So these are a type of immune therapy, not the ones that we commonly use today, but an early form of immune therapy that's essentially sort of a gas pedal for the immune system. And truthfully, these did not work incredibly well. So back then, a long, long time ago, if someone was diagnosed with a stage 4 kidney cancer, the average time from that diagnosis to, unfortunately, someone dying from their disease was only about 1 year. But even then, even what was really not a bright moment for treatment of kidney cancer, there were some patients who received things like high-dose IL-2, a type of immune therapy, small number, maybe 5 or 7%, that really had tremendous outcome in the long term. They really had, their disease melt away, and years later, they were still having a response. So even then, even in where we didn't have a widespread effective therapies, there were these isolated cases of an immune-based therapy really having these dramatic responses. There was a major change that happened about just under 20 years ago with the introduction of molecularly targeted therapies. And the basic idea was as knowledge of the biology of kidney cancer improved, and this is particularly clear cell, which is the most common type, people start to realize that some of those alterations that exist in kidney cancer's molecular alterations, like a dependency on forming new blood vessels, might actually be targetable in some way. As that began with drugs like sorafenib and sunitinib in late 2005, early 2006. And these drugs both, really did have an impact. We can see here for sunitinib, they meaningfully improved clinical outcomes for patients. They meaningfully improved how long patients were living, and that's really important. We see the time from diagnosis to death really increasing from about a year to about 2 years, an important improvement. But this was not something that works long term. This is something that had worked for some amount of time for patients, but in almost all situations, ultimately the cancer would unfortunately find a way around it, would find a way to escape and to start growing again. And so these were things that prolong life, but weren't getting rid of disease. We're not in the realm of a potential cure. Really, a breakthrough happened in 2015 with the introduction of our current generation of immunotherapies, which are immune checkpoint inhibitors. So rather than pressing on the gas pedal, this does the opposite. This kind of releases the brakes on the immune system. And the way I sort of conceptually think about it is that your immune system's job is to recognize things that are foreign in the body that look different and to get rid of them. You get a bacteria, you get a virus, you get the flu, your immune system should ramp up, recognize that foreign entity, and ramp back down. And it's important to note the ramp back down part, that if you get the flu, you want your immune system to ramp up, but you don't want to stay at that heightened state forever. You will ultimately want your immune system to come back down to its normal state, to come back to its baseline level. And so the immune system has mechanisms to both ramp up and ramp back down. And so cancer looks really foreign to the immune system. It looks like a foreign entity. And so why isn't the immune system getting rid of it? Why isn't recognizing it, doing its job of recognizing it as a foreign entity and getting rid of it? And it's complicated. There's lots of potential reasons, but one of those is that it effectively, in some cases, is able to press on the brakes of the immune system. That same thing that the immune system uses to ramp back down, cancer can exploit to press on the brakes and keep the immune system from recognizing it. And so what these immune checkpoint inhibitors do is essentially release those brakes, allowing the immune system hopefully to do its job of recognizing and attacking cancer. And the first trial of this was the Checkmate 025 trial. This was published in 2015, the first of a class of drugs called anti-PD-1 drugs that meaningfully improved survival. This is for patients who'd already received tyrosine kinase inhibitor, molecularly targeted therapy. And then really the current era, which is combinations of therapy right at the diagnosis, right at first diagnosis of advanced or metastatic cancer. And we see that the outcomes have improved tremendously, where we started from a median time from diagnosis to death of about 1 year is now increasing with the latest trials to over 4 years. So huge, huge improvement. But I think really notable is that there's a proportion of patients who are not just living longer, but are continuing to do well with these therapies even years and years and years later. I do want to highlight it's not, unfortunately, the majority of patients. So we're still at a point where we need to do better, but it's, I think, the first time where there's a reasonable population of patients who if they're able to have these medications work, if these medications do the job they're supposed to, can work for years and years and years. So that's where we are right now. And so I've presented this previously at a conference, but I want to bring up the idea of how do we think about these immune therapies? I mentioned a couple already, cytokines. I mentioned immune checkpoint inhibitors, and there's a lot more along the way that you might hear about in clinical trials, CAR T cells, T cell engagers, new cytokines. How do we sort of conceptually think about these and sort of make sense of it? So I have a really simple way of thinking about it. This is something that adapted from a mentor of mine, Kathy Wu, and sort of adapted over the years. And the idea is a simple one. You think of the immune system as a car that's packed full of T cells, in this case, immune cells that are ready to attack the tumor. And you have to do your best to get the car to the tumor, to drive it to the tumor so that it can do its job. So what are the ways that we can rapidly and effectively get that car to the tumor so that the immune system can effectively attack the cancer and get rid of it? So one way is releasing the brakes, taking your foot off the brakes, and that's exactly what these immune checkpoint inhibitors, these anti-PD-1 drugs do. One way is by pressing on the gas pedal, and that's what the original cytokines did, like interferon and high-dose IL-2, and I'll talk about some newer forms of those as well that are currently in development. these are both types of treatments that you can imagine. Just like a car, if you press on the gas pedal or release the brakes, the car is going to go faster. It'll get, wherever it's going, it'll get there faster, but it doesn't give you any directionality. It doesn't give you any ability to steer. So you hope that with these therapies, the immune system gets activated and attacks the tumor, but we know that in certain cases it doesn't, it's not successful. And in certain cases, it'll attack other things. It'll attack normal parts of the body and cause side effects or toxicities. And so there's been the idea of how can we maybe steer the immune system, not just turn it on, but really steer it towards the tumor where we want it to go. And that's the idea of adding a steering wheel. And there's a whole host of ways to do this that I'll broadly call antigen-directed therapies. Antigens are things that the immune system recognizes when it wants to attack. And so can we use antigen-directed therapies to try to steer the immune system towards the tumor? And then finally, the idea of clearing the traffic. Even if you do all of the above things and you steer the immune car perfectly towards the tumor, it's active, it's ready to go. If there's a lot of things in the way, then the car's still not going to be able to get there. And we'll talk about what some of those things in the way could be. Everything from other types of cells to the bacteria that live in our gut, the gut microbiome potentially having a role. And so with this framework in mind, I want to very, very briefly step through each of these different buckets. When we talk about releasing the brakes, I'll talk about current therapies for kidney cancer, particularly clear cell disease, and kind of my approach to it. But then I want to highlight some ongoing clinical trials. A lot of these are very early. They're phase 1 trials, so they're the first time they're being tried in humans or first time in this disease. But to give you an idea of some of the excitement of things that are going on in terms of immune therapy development within kidney cancer. So we'll start with releasing the brakes. And so the cells that we think of as having the most anti-tumor effect, the sort of soldiers of the immune system that we think of as being able to attack and clear cancer potentially, are these CD8 T cells. And these CD8 T cells have a whole host of brakes on them, which are shown here. And those brakes can be engaged by tumor cells or by other types of cells within the tumor. And when those brakes are pressed, then those T cells can't do their job. And the current immune therapy really focuses on only 2 of those brakes, which is a brake called PD-1 and a brake called CTLA-4. And that really forms the mainstay of current therapy. So let's talk a little bit about current therapies, because this landscape is rapidly evolving. This is, again, for clear cell histology, and I'll sort of mention briefly the non-clear cells or variant histologies as much more of an open question. But we have divided up into first line, so the first treatment to be received, and also the subsequent treatment. And I would say for the last number of years, we've also paid attention to a risk assessment of how aggressive a kidney cancer might be, something called the International Metastatic RCC Database Consortium, or just IMDC for short, and basically breaks down into either a good risk or favorable risk tumor, or something that's a high risk, an intermediate or poor. I will say that it is going to be a little bit more controversial of whether you really need to use these. And I think the latest guidelines actually suggest maybe not using these to pick therapy. And so when we look at the different types of therapy, they really fall into largely 2 big buckets. One are targeted therapies, of which there's a lot of different types. The TKIs I mentioned that target new blood vessel formation, not incredibly commonly used, but mTOR inhibitors are a possibility as well. And one thing I haven't shown here, but belzutifan, a relatively new drug that targets a particular important protein within kidney cancer cells. But we see really immunotherapy, particularly in the frontline setting, really being the dominant type of therapy that one would use. And we see the far majority of patients should be receiving some sort of immune therapy as their first treatment for metastatic clear cell kidney cancer. Now, there are multiple different types of therapy approved. There's actually 5 FDA-approved regimens, one of which is probably slightly less efficacious. It doesn't have a big survival benefit like the other ones, but certainly a whole handful of different immunotherapy regimens. One regimen that's pure immunotherapy, targeting 2 of those breaks, and then the other regimens targeting 1 of those breaks, anti-PD-1, together with a targeted therapy. And so the first thing I want to talk about is how do we sort of choose between them? What is the right answer between these 2? And my short answer is these have never been compared head to head. I think very intelligent people can actively debate which one of these to sort of use. But I'll give you sort of my 2 cents about it. And it largely stems from what I think are their strengths. And then I use that to help sort of guide me in terms of how I think about it for an individual patient. So when I think about the IO, the immunotherapy plus the TKI regimens, and I highlight the three main ones that are used clinically, the thing that sort of jumps out at me is how effective they are at shrinking a tumor in the short term. That the far majority of patients, anywhere from 55% in one trial all the way to over 70% in another trial, have their tumors shrink by a pretty substantial amount. When we say shrink, it's by at least 30% or more. And very few patients, as low as 5%, have their tumor grow. So we call this very high objective response, really high good shrinking tumor, and unlikely that at least at the first scan or two that it's good kidney cancer is going to grow. So that's actually really important. It's really good at shrinking things in the short term. So if it's so good at shrinking things in the short term, why wouldn't we just use it all the time? And I think where the pure immunotherapy really shines is its outcomes in the long term. And so maybe in the short term, it's a little less immunotherapy rather than, 50, 60, 70% of people having their cancer shrinks dramatically. Maybe it's only 40%. It's less. But if the cancer does shrink, the chance of it continuing to shrink and continuing to at least prevent it from growing for years and years and years is fairly strong. So this is a curve which shows the duration of response. So this is a group of patients who had their kidney cancer shrink initially. So that's a big if, right? That's not most patients. That's about 40% of patients. But with pure immunotherapy, if their cancer shrinks, what's the chance it's going to stay shrunken 2 years down the line, 3 years down the line, 5 years down the line, 6 years, 7, 8 years down the line? And you can see, this is not something that's staying at 100%. It's not that just because it shrinks at the beginning, it's a guarantee that it's going to stay shrunk. But the flip side is if we look 5, 6, 7, 8 years later, about half of those patients who have tumor shrinkage, it's still shrunk that many years later. And so this is really an incredible advance. Again, as we think back to 20 years ago when the average time was about a year from diagnosis to death, these are patients that are looking at 6, 7, 8 years later, and they're still doing well with their therapy. So when I look at these two factors in my mind, one, really, the pure immunotherapy seems to provide really the potential, at least, for long-term disease control. The other one, the IO-TKI, is really good at shrinking the tumor in the short term. Here's how I sort of think about it. This is sort of my paradigm, and there's no one size fits all. So everything's individualized. There are a lot of caveats here. This is assuming someone needs treatment. There are certain times that people have even a kidney cancer that's spread, but it's incredibly slow growing. It's not growing at all or growing by millimeters that we might even watch it closely. So this is assuming someone actually needs therapy. This is my typical paradigm, the typical way I sort of think about it. The first is there really a limited number of sites of disease? What that number is an evolving concept. Historically, it would be one. So this is someone who had metastatic kidney cancer, but there's only one tumor that came back. It came back in the lung 5 years later, and there's no other site of cancer. In that case, I still think about not only medicines, but really multidisciplinary collaborations with surgery, with radiation oncology, with interventional radiology, really thinking about maybe just attacking that one spot, so-called local therapies. That's the minority of patients that I see. The majority of patients I see with metastatic or advanced kidney cancer have a number of different spots. And so the next question I ask is, do they have something in their tumor that's called sarcomatoid feature? This is something that is sometimes found on the pathology report. It's something that describes just literally the way the cells look, that they almost look muscle-like. They look very different from normal kidney cancer cells. But the reason why this is important is historically, this is a really aggressive type of kidney cancer that didn't react incredibly well to those targeted therapies. But for some reason, they seem to potentially respond particularly well to immune therapies. And so that's present. That really pushes me to use a pure immunotherapy response. It's not that the majority of patients have this. It's anywhere between probably 10 and 20%. But if that's there, it's something that strongly pushes me towards pure immune therapy. If not, and now we're in the bucket, this is most patients that I see, this is probably 80% plus the patients that I see. My big question is, how quickly do we need to shrink the tumor? Basically, do we have to think about the very short term, the next few weeks or a couple of months, or do we have the sort of benefit, the luxury of thinking a little bit longer term? And that's very patient specific. There are some patients where the cancer is growing so rapidly, people's condition is really declining so quickly. You don't have the luxury of thinking about 3 or 4 years from now. You really have to think about the weeks ahead of you, the months ahead of you. And if that's the case where things are really evolving rapidly, you want to use the drugs that have the highest chance of controlling the disease in the short term. And that's where I use those IO plus targeted therapy regimens, because they have the 60, 70% response rates, chance of shrinking the tumor. That's, again, not the majority of patients that I see. The majority of patients I see, they need treatment, that's for sure. But it's not that they need the cancer to shrink 3 weeks from now or 2 months from now because they're in such dire situation. And so for those patients where we have the luxury of a little bit of time, I really think heavily about immune therapy. And that allows us to at least consider not just what's going to happen 3 months from now, but potentially 3 years from now or 5 years from now. And that's where I think immunotherapy really has its strengths. So that's the current landscape. Where are we going? Well, if two drugs work better than one, and that's what we've seen. There's been a thought maybe 3 drugs will work better than 2. And so there have been a couple of trials that have tried to really examine this. One of them has been published already, which is combining 3 drugs together, 2 immune therapies plus a targeted therapy. I think the jury's still out. It ended up that as you combine more drugs together, the side effects, the toxicity of these drugs really becomes more prominent. And so it's not clear that the extra maybe increase in response and these sorts of things really outweigh the downside of the toxicity here. So that's the one trial that's already been reported. But there's another large trial that's exploring a couple of different combinations of 3 drugs. One using a new HIF-2 alpha inhibitor, one using a version of CTLA-4 blockade, and this is not reported yet, so we'll see that data. But I also think there's clever approaches where you maybe don't have to give all the drugs at the same time, so-called adaptive design. And this is the trial Pedigree, which is, I think, just about finished accrual, maybe I've just finished accrual, so just finished getting the patients enrolled, and now it's in the follow-up period. But the idea is to start with a pure immunotherapy approach and then adapt as you go. If it's working really well, there's a complete response, just continue with the immunotherapy. If it's not working at all, you say immunotherapy is not working, you go to targeted therapy next. But if it's kind of in between, it's sort of not rapidly growing, but it's also not completely gone away, then randomizing to either just immune therapy or trying to add a target therapy at that point and see if you can improve the response. And so this is a trial that we'll hopefully hear from in the coming year or so. There's a lot of open questions now for advanced kidney cancer, and I'll just mention a couple of them. And this is, if there's time, I'm happy to sort of discuss. One is that all of these trials are done before there was adjuvant pembrolizumab, so adjuvant Keytruda. So this was, patients had surgery, and if they recurred after surgery or they had metastatic cancer at diagnosis, these are treatments they'd get as the first type of medicine they get. Now we're in a slightly different era where there's lots of people who might have surgery and potentially get Keytruda, pembrolizumab afterwards. And then if the cancer still comes back, it's less clear what is the best sort of path. And so that's something we're going to have to figure out as a community. I talked a little bit about risk stratification and whether that should play a role or not. And finally, in my mind, one of the big open questions is, how do we treat these non-clear cells? We often bucket them together and probably shouldn't, but papillary and chromophobe and translocation and unclassified and many others. What is the best way to treat them? And I think we're going to have to really decipher that individually. So I'm going to skip this just in the interest of time. I'll briefly mention the highlight, which is if someone's gotten an immune therapy already and then had the cancer, it unfortunately didn't work well enough, and the cancer grew, the cancer progressed, should you give a targeted therapy by itself after that, or should you give a targeted therapy plus another challenge of immune therapy right afterwards? And the answer is I think the weight of data is now that you shouldn't do that. There's now at least one, but probably a second trial that's coming out now saying that immediately re-challenging with immune therapy after it hasn't worked to begin with is probably not of a huge benefit. That's not to say that re-challenging with another immune therapy that's different or doing it later down is definitely a wrong thing to do, but immediately giving a very similar drug, another anti-PD-1 drug, just right after the first one stopped working is probably not a successful strategy. So the last thing I'll sort of mention in this space is it's really rapidly developing. So I sort of highlighted here a couple of those breaks, but you can see just in this toy figure, there's lots of other breaks that can be released. And now we're in a mode where this clinical trial is really evaluating most of these. And so there's a lot of data that's going to hopefully emerge in the coming years where these other breaks will be tested and see if we release them, will that have a beneficial role in kidney cancer as well. One that I'll sort of highlight, or a couple actually. So one is an improved version of the existing break. So we, again, talked about inhibiting CTLA-4 and anti-PD-1, this sort of next generation of an anti-CTLA-4 drug called BOT or botensilimab. So there's an active trial evaluating if that is better than the current standard of care. And there's lots of new checkpoints. One of particular excitement is a checkpoint called HPK1, which actually impacts a lot of immune cells, not just T cells, also other important immune cells for generating anti-cancer response. And this is really early. It's only in phase 1 trial. But the reason why it's, I think, generating some excitement is as they've started to try this for the first time in humans, they tried it in a lot of different cancer types. And when they tried in a lot of different cancer types, 2 of those patients happened to have kidney cancer. And out of those 2 patients, both ended up doing reasonably well. So one patient actually had a complete response, had their tumor really disappear, ultimately grew back about 8 months later, but an initial really dramatic response. And the second patient had stabilization of their disease, but lasting well over a year. And so it's early days for these, but just to give the general highlight that we're just scratching the surface, I think, of potential immune checkpoints that we can target, breaks that we can release. So that's our first bucket. Our second bucket, which is pressing on the gas pedal. And so again, I'll go back to my diagram here where we have all of this evolution of therapy. But if we go back to those early therapies, while most patients unfortunately did not do incredibly well with things like high-dose IL-2, they were the rare patients who had remarkable responses. It might be as low as 5 to 7%, but those patients who had, for instance, a complete response, we can see that years and years later, this is the 10-year mark here, this is a 15-year mark, the far majority of those patients are alive, a decade or 2 decades later. And so, there is clearly something about pushing on the gas pedal for a select few patients that might have a benefit. And so how can we learn from that and potentially do better for more patients? And so one of the things I think we've learned over the years is what are the parts of the immune system that we think are beneficial for attacking a cancer, and what are the ones that are probably less beneficial, and what are the ones that might actively be harmful for generating a good response against cancer. And it turns out IL-2 is kind of like using a hammer, that when you give IL-2, it is a gas pedal not just for the good cells that we want to turn on, those CD8 T cells, but it's a gas pedal for cells that might cause a lot of side effects, things like NK cells, or it's a gas pedal for cells that actually might be counterproductive, that might actually harm the body's ability to mount an immune response against cancer. And so when you give high-dose IL-2, you're kind of hoping, that the good cells get enough of it, the other ones don't, and it sort of outweighs the good, outweighs the bad. But it's, again, it's sort of using a hammer here. And so are there ways to potentially cleverly engineer cytokines like IL-2 to be more specific? And so there's lots of attempts to do that, not just one. But I'll highlight one in particular, which is a relatively straightforward strategy, which is have an antibody that literally targets CD8 T cells, the T cells, the cell that we think is a good anti-tumor cell, and tag along to it that IL-2 molecule. And what we can see, this is in primates, this is not yet in human studies, this graph, but that it basically has virtually no effect on the cells that we don't want to turn on, the NK cells, those immune suppressive T regulatory cells, the bad cells, but it has a dramatic increase in expanding and increasing the number of good cells, the CD8 T cells. And so this is a trial that's now actively in phase 1. It's for both kidney cancer and for melanoma. A number of sites are open that are enrolling, but I want to highlight it's not the only one. There's other clever strategies. This is by clinical cytokine that also tries to really target the IL-2 to the cells that we want it to go to. But IL-2 is not the only cytokine. There's lots and lots of other ones as well. And so, one of the ones that has been studied now for, almost 2 decades is IL-18. And it always seems that it really is a great agent to improve the efficacy of immune cells, potentially their ability to attack cancer, but it's never panned out in the clinic. And it's a shame because kidney cancer, shown here, is actually one of the highest expressors of IL-18. So it expresses lots and lots of it, but doesn't seem to be doing the job of actually turning on the immune system. And it turns out that likely one of the reasons is there's actually a checkpoint that's sort of built in, that as IL-18 is expressed, there's another protein that's produced, the IL-18BP, or binding protein, that basically sops it all up. It acts as a sponge and sponges it all up so that the amount of IL-18 that's available to actually impact your immune system is very, very low. And we can see that here, that in kidney cancer, lots of IL-18 and IL-18 receptor, but also lots of this binding protein, the sponge, which sops it all up. And so clever engineers, Aaron Ring, who's actually now in at the University of Washington at Hutch, was previously at Yale. He's a very, very smart protein engineer. He engineered a form of IL-18 that was resistant to binding this IL-18BP, called decoy-resistant IL-18. And so now it's not able to, the sponge can't sop it up anymore. Now it's available to turn on the immune system. And at least in preclinical studies, it has some pretty dramatic effects. This is only in mice models, so we have to have a word of caution. But this is something, again, that's now actively being investigated, both for kidney cancer and for melanoma. And so we've talked a lot about how to get the car moving, releasing the brakes, pressing on the gas pedal. But as I mentioned, none of that gives it directionality. None of it actually steers the immune system towards the tumor. And so a way to do that, in my mind, is really through antigen-directed therapies. And I do have a bit of a framework for thinking of this, and it basically falls along a couple of buckets. And I'll show you so 2 columns and 2 rows. So there's going to be four total categories here. One is, what are you targeting? So there's a few things that are present on the surface, on the outside of each cell. It's relatively little. Only about 10% of the proteins in a cell are shown on the cell surface. But if it is, then it sort of makes it easier to target because it's already there on the cell surface. The other is the remaining proteins, the other 90%, which are not on the cell surface. And those still have a way to be recognized by the immune system, but it's more complicated. Those proteins have to be chopped up within a cell, or cells normally do this, and cancer cells do this too. They have to be chopped up, and little pieces of them are sort of shown on the outside, not the whole thing, but little fragments of them are shown on these HLA molecules, which are present on all of our cells. And the reason this is more complicated is most people have widely different HLA types. And so what might be an immune target for one person might not be an immune target for the next person because they have really different HLA types. So those are 2 big buckets. The other actions are the rows here, and that's whether the treatment has to be personalized or off the shelf, meaning you can just give it right away or something has to be custom made for a patient. And so with these buckets, we can begin to sort of fill these in. The first are the classic CAR T cells. This is less, has not had an initial success. They were first tried, not the current generation, but old generations were tried over a decade ago in kidney cancer. But these are ones that have had really tremendous success in some blood cancers like myeloma or lymphoma. The next big bucket are things that still target things that are on the surface of the cancer cell, but are available off the shelf. And there's a whole host of things that are available here, including antibody-based therapies, and we'll talk a little bit about that, but also new generation CAR T cells that are off the shelf, the ability of taking T cells from someone else, engineering them in a particular way, and designing them to attack kidney cancer cells. Now, as we move into the more restricted, we have a history of vaccines that are available off the shelf. Unfortunately, none of them had a dramatic effect. But I think we're in a kind of a newer area where we have the ability to potentially personalize vaccines. And this is in its really early days, but at least some early emerging data that there might be some promise to this approach. So I'll talk about just a few of these that are sort of in the clinic already. One of these are these CAR T cells. So again, these are T cells, in this case, T cells from someone else, immune cells from someone else, but they're engineered, 1, so they hopefully don't attack the normal parts of the body, 2, so that your immune system doesn't get rid of them right away. But then 3, they're designed with these chimeric antigen receptor, these CARs, which are basically things that can recognize something on the surface of a kidney cancer cell. Most of the current ones recognize a protein called CD70. And there's a couple of early trials of this, which I think shows both the difficulties and the potential promise. So the first was called CTX130. It's a cobalt RCC trial. And we see each of these lines here is one patient with kidney cancer treated with this CAR T cell. And basically, the far majority of patients, everyone except the first, did not have their cancer shrink meaningfully. And so there's a lot of people who see that and say, oh, that's very understandably very disappointing that there's not widespread shrinkage. However, there was one patient, and that's the patient at the top, who didn't have a big burden of cancer, but what was there did shrink. It actually went away. And over 3 years later, it still had not recurred. And so this is something where you can look at it, I think, from both sides. On the one hand, the far majority of patients aren't benefiting. On the other hand, it's really a proof of concept in my mind that this is a therapy that for some patients has at least potential. It just really needs to be optimized and evolved to positively impact more patients. There's a second trial from Allogene called the Traverse trial, which is a different design, but again, targeting the same thing, another CAR T cell trial. And here we're starting to see some better responses, still not high, about 17% responses. But when they specifically look at those tumors that have the target, the thing that the cells are meant to recognize, CD70, we see very, very, very small numbers, but we see those are the patients that tended to have their cancer shrink if the cancer actually expresses the target. And so I think already we're starting to see these things evolve and with each iteration get a little bit better. It doesn't always require a cell therapy to bring immune cells towards the tumor. There's other strategies, including what are called T-cell engagers. These are heavily engineered and modified antibodies that basically on one side grab onto the tumor and on the other side grab onto your immune cells, the T cells, and try to bring them together and turn on the T cells. So use the T cells that you natively have to try to bring them to the tumor and turn them on. And this is one example of that, targeting something on the surface of kidney cancer. That's clear cell kidney cancer, EPP3, which is fairly widely expressed. And this is something that's, again, in a phase 1 first-in-human clinical trial in kidney cancer. And the last thing I'll talk about for this bucket is the idea of a personalized vaccine. This is in its very early days, but the idea really bores from some early successes in other cancer types like melanoma. And the idea is, well, if we could actually steer the immune system specifically towards what makes the tumor unique, different from the other parts of your body, maybe we can have more success. And so this was a small trial that we ran back when I was at Dana-Farber. There's a patient with really high risk cancer that could be removed fully by surgery, and the KidneyCAN can be sequenced and identify specific DNA changes, mutations that we think would be good targets for disease. And this was completely personalized, so no two patients had the same targets. And we picked up the 20 best targets, make a custom vaccine, and did it after surgery to try to steer the immune system. And this is emerging data, so it's not published yet, hopefully in the coming months. But the first question is, can we even do this for kidney cancer? It hadn't been done really before, and the patients we were able to successfully design and manufacture a vaccine. And so this has actually had some early encouraging results, and is now led to a phase 2 trial using technology, but a phase 2 trial very similar for patients with high-risk kidney cancer. It's about 280 patients. It's open in a number of countries across the world, and people are randomized either to get standard care medicine, Keytruda by itself, or with a placebo, or Keytruda plus a personalized vaccine targeting these neoantigens, these custom antigens. And then finally, the last bucket I'll mention very, very quickly is clearing the traffic. And there's lots of other types of traffic that prevent the immune system from doing its job. I mentioned other types of suppressive immune cells, but there's also extrinsic factors, and one of those is the gut microbiome. We have lots of bacteria that live in our gut, probably more bacterial cells than we have human cells in the body. And some of those can really be helpful for immune responses, but some of those can be harmful. And so there was an observation that there was a particular bacteria that seemed like it might be helpful, that it's actually available as a pill, as a common sort of digestive for upset stomach in Japan. And people had recognized that those patients who were on it and got immune therapy seemed like they might have done a little bit better. And so this was formally tested in 2 trials where this live bacterial product called CBM-588 was given together with a standard medicine, either dual immune therapy or immunotherapy plus target therapy. And these are really small, so big, word caution, only 20 patients in one group or 10 patients in the other. But in both of these trials, the patients who got this live bacterial product, this pill with this live bacterial product, seemed like they had better outcomes. They had better response to the medicine. They had better time living on the medicines. And so really intriguing data. This is something that is now needing to be validated at a much larger scale. But the idea that modulating these extrinsic factors like the gut microbiome might have a benefit. So I'll sort of end off with a couple of notes about kind of where do we go from here? What's sort of next for the treatment of kidney cancer? And to sort of help guide that, Dr. Tykodi mentioned I run a research lab about 80% of the time, but a huge portion of my time is really seeing patients with kidney cancer. That's the only type of cancer that I see. And I always sort of learn from the patients themselves, what's the most important thing to them? And this is something that Dina Battle, who runs an organization called KC Cure, had done a survey among kidney cancer patients, but really resonates with the patients that I see in clinic as well. We surveyed what is it that patients prioritize most? And there's lots of really important things here: toxicity, reduction of symptoms, all incredibly important. But by far the thing that was weighted the most important was essentially the chance of getting rid of the cancer, the aim for cure, the chance of eliminating all disease, and something that's going to last for a long time. That's really the dream, the goal. And I think we're not there yet, unfortunately, with the majority of patients. But I think the path to get there has to come through immune therapy. I think that's something that I sort of firmly believe at that point. It's not that other therapies aren't important. They can meaningfully improve both quality and quantity of life. But when we sort of really sort of swing for the fences and aim for cure, it's going to be immunotherapy. That's the path to get there. And it's really going to require a back and forth between the clinic and the lab, what Dr. Tykodi mentions, because we're going to have to learn from what we see in the clinic, but then we're going to have to bring that to the lab and understand the fundamental biology, immune biology of kidney cancer. It's different from other cancer types, so we can't always extrapolate from lung cancer, breast cancer, melanoma. We really have to understand kidney cancer specific biology, and then we have to have a path to bring things from the clinic to study in the lab, but also go in the reverse direction, rapidly learn things that we're then able to bring back to the clinic in early phase clinical trials and rapidly iterate back and forth. So with that, lots and lots of people to thank, both in my laboratory, some key collaborators, our funding sources, my Yale colleagues, but really want to thank patients and their families who make all of these studies and the work that we do possible. And this is my lab, and my email address is available for others as well. And again, thank you so much for the invitation. And don't know if there's time, but if there is, I'm certainly happy to take any questions.
Thank you, David. That was tremendous. I don't know if you're able to see the chat, but there were a couple of questions that came in while you were talking. So we give a couple of minutes, maybe we can tackle the questions here. Are you able to see those, or I can read them?
Yeah, absolutely. Should I just go from the top down?
Yeah.
So the first question was, does tumor shrinkage always correlate to overall survival time? The answer is it correlates, but is not perfect. So, the question is, if you see shrinkage, does that mean that's going to be a longer overall survival time? And if you don't see, that's going to be shorter. I think that's sort of more generally true, but it's not that it's a perfect measure. And so we've actually looked at this, what we call sort of intermediate endpoints, because ultimately overall survival is what we care the most about. And so if we look at an intermediate endpoint, something that's shorter term like shrinkage, how well does it predict overall survival? And the answer is it predicts it pretty well, rough numbers, 60, 70% kind of correlation. So it's pretty well, but that's still far from 100%. Is RGCC a test that could help determine focused therapies? I'm sorry, I'm not familiar with that acronym, so I'm happy to answer.
I think it's circulating tumor cell assay.
Oh, yes. So it's a good question. So circulating tumor cells, and I would say circulating tumor DNA as well, has been very, very challenging in kidney cancer. Kidney cancer tends to shed quite a bit less DNA than other tumor types. It's actually more similar to glioblastoma than most other tumor types in terms of the amount of DNA shed. So a lot of the things that are really popular in other cancer types, like Signatera testing and these blood-based biomarkers, they are much more difficult in kidney cancer. Circulating tumor cells are an interesting thought. Getting the whole tumor cell. I know Josh Lang has done some really interesting work at the University of Wisconsin on these. I think nothing that's been a slam dunk in terms of either predicting, is the cancer going to come back, which would be a key question after surgery, that really critical one, not quite there yet. Or is this going to respond to therapy? Definitely yes or no. So in my mind, radiology scans are the gold standard. There is more development. There's other approaches using not just DNA mutations or alterations, but how the epigenome, how different modifications to that DNA happen in cancer versus not. And people have looked at methylation and other epigenetic modifications, and those I think are promising. But the short answer is nothing unfortunately ready for prime time yet. The next question is, I'll just read out. My metastatic disease was diagnosed at the end of 2020. I've been through immunotherapy, IO-TKI, and now belzutifan. Are there more treatments I can expect to see available to me? I had a brain tumor with successful resection, but evidently that makes trials unavailable. And so I think that's a really important point. And I think something that's unfortunate in the way that a practical constraint in how some of these trials are done, in that some of them are trying to get a very specific population of people and don't allow people who have had prior tumors in the brain. I think that is getting better, is the short answer. I know not a lot of the trials that we have open here, and I imagine likely at Hutch as well, they don't preclude people who have had brain metastases. They require that the brain metastases are under control, that they're not actively growing, that they've been treated, for instance, they've been irradiated or resected, but just someone who's had it in the past doesn't automatically exclude someone from a trial. And so my hope is more and more we see that in these trials, that'll make hopefully more trials available. The next question is from a person who's 51 years old, extremely active, and that with belzutifan reaching the end of therapy. And so the question is belzutifan the last thing that one could do? And the short answer is no. Obviously, everyone is specific, so it's hard to comment on a specific case. But I'd say belzutifan, which is this new HIF-2 alpha drug, it's used sometimes as early as the second drug that people might receive. That's sometimes maybe a bit too early, but that's technically approved for that as well. And there's certain cases where that's maybe the best for certain patients, but often is used quite a bit later. And so frequently there are other standard of care medicines available, but this is where I think largely about if someone is doing well, otherwise they feel okay and they're active, and it's within their wishes, thinking about clinical trials. I think clinical trials have a huge range. Some of them are, slight tweaks to what already exists, take an existing drug or an existing regimen and try to add to it a little bit. But other ones, as I've mentioned in the talk today, are really first in human. They come with risks, of course. They come with both a time commitment and risks. But those are things when I talk to my own patients who have seen a number of different types of therapy, it's a conversation we often have that we don't know how this is going to work. Some of them are promising from the laboratory, but some patients say, really, I do want to take that risk because one is I do want to help move the field forward, push the field forward. But second of all, there's a chance that we don't know, but one of these early phase drugs could be helpful for their own cancer.
David, there's two more questions. Maybe you can make this the last comments. Two people asking about non-clear cell histologies and options. One person specifically chromophobe and another with some of the other non-clear cells. So maybe some comments about that space, and then that'll have to be it.
Yeah. No, that sounds perfect. I think the short answer is this is a really huge area of need. I think I'll take chromophobe out of it for just a moment and sort of related oncocytic tumors. I think we think of papillary and unclassified, and a lot of these other tumor types can certainly be responsive to immune therapy. We have kind of multiple lines of data, but I think probably on average, less responsive than clear cell. So it's not that immune therapy is unavailable for those, but I think we sort of have to do better. The paradigm so far has been take what's available for clear cell and then just apply it to all of these different histologies. I think understanding the biology of these different tumors is going to be critical to having sort of better and targeted therapies. But we now have a couple of reasonable studies where an immune therapy plus a targeted therapy, IO-TKI, seems like it has reasonable efficacy, at least in terms of shrinking tumor for a lot of these variant histologies. Chromophobe has always been difficult, and that's one that I think has been less responsive to immune therapies. We've tried to study a little bit about why, and it looks like there's many fewer immune cells, particularly T cells, in the chromophobe tumors, and the ones that are there probably aren't capable of recognizing the cancer. And so I think, have to think in a really different light for chromophobe. How do we get more T cells into the tumor? And how do we get the specific T cells are going to be able to recognize the tumor? But the current generation of immune therapies, unfortunately, is much less successful for chromophobe. There is some interesting data coming out of Sloan Kettering where other cytokine therapies like IL-15 really have some preclinical data that they might be beneficial in chromophobe, but we're starting to work together to try to figure out how can we get a trial specifically for chromophobe kidney cancer that we can actually rigorously test that.
Well, David, again, thank you so much. Extraordinary talk, wonderful overview that really sets the table for the rest of today's program. So again, I thank you so much for joining us. You're welcome to stay if you have time, but if you have to sign off, we understand.
On hospital service, so I'm going to head back to the hospital now, but thank you again so much for the invitation.
Okay, excellent. Well, thank you. So let me turn it over to our next speaker, Dr. John Gore, from our own faculty. Many of you probably know Dr. Gore and may call him your doctor, a professor in Department of Urology here, the Jesse H. Bridges Endowed Professor in Prostate Cancer Research. And John's going to talk to us this morning about our own kidney cancer multi-specialty clinic program. John.
Thank you so much, Scott. I really appreciate it. Again, it's really wonderful to see everyone's name on the participant list. This is not unique in that today Scott gets to introduce me and I get to introduce Scott. But as many of you know, we also partner together in the care of a lot of our kidney cancer patients. And I think this is a great example of how we do that. And so our kidney cancer multidisciplinary or multi-specialty clinic started in 2017. And I wanted to just talk about sort of the who, why, what of the KCMC and talk about the evolution of the KCMC because, kidney cancer management, as Dr. Braun just demonstrated so clearly, has changed a lot in the last 7 years. And our kidney cancer multi-specialty clinic has had to evolve with it. And I think it's demonstrated a nimble ability to keep up with the changing paradigms of care for kidney cancer. So I would love to give everyone an update on our KCMC. So what is it? Well, oftentimes when someone has a complex cancer diagnosis where they have to see multiple cancer specialist physicians, it can be a very difficult coordination challenge. So our system is such that we have a center down in South Lake Union, the Fred Hutch Cancer Center campus, but many of our surgeons are at the University of Washington Medical Center. And so you have these disparate physical footprints, and complex scheduling with busy physicians. And so you may see someone like Dr. Tykodi one day, and it may be 2 weeks to see myself or someone from radiation oncology. And so several years back, Dr. Tykodi and I pitched the concept of the KCMC to our cancer center leadership, who are very supportive. And the concept is, could you in one stop visit with all the doctors that might be engaged in your kidney cancer care? And the main cancer doctors that we think about for that are medical oncology, because as Dr. Braun just gave a thorough overview of, most patients with metastatic kidney cancer and even some patients with localized kidney cancer are treated with medical therapies, or what we call systemic therapy for kidney cancer. There is definitely a role in a lot of cases for radiation, whether it's to a site of metastatic disease or even to the primary tumor. So we involve our radiation oncology colleagues as well. And then in some cases, more likely today, in some cases, less likely today, we try to consider what surgical options are available to patients as they navigate their own kidney cancer journey. So the concept is that in one clinic, you can visit with all the doctors that might be engaged in your kidney cancer care. But it extends beyond that as well. There are a number of services, especially at our cancer center, that are available to support patients. And one of the key components of the KCMC is nurse navigation. It's a very stressful ordeal to navigate a new cancer diagnosis. And so we have a nurse navigator who basically shepherds patients not only through their intake into the KCMC, but also their follow-up thereafter, and their engagement with our health system sort of throughout their cancer-specific journey. Genetics are an increasingly recognized component of understanding not only why a person developed kidney cancer, but sometimes potentially how we can help treat their kidney cancer. And so there are some guidelines about who should have genetics testing. And we have a genetics counselor that sees, I would say on average, about half of our patients that present for evaluation in our KCMC. And we have a great talk later from Ray Palko that highlights the importance of nutrition. This is a question that I know I get a lot from patients. I know Dr. Tykodi gets a lot from patients, which is how can my nutrition impact not only my overall well-being and fitness, but potentially impact my cancer behavior. So it's not just seeing the doctors in the clinic. It's also seeing some of the supportive services that help people navigate their kidney cancer journey. So what are we seeing in KCMC? Well, when we first devised the kidney cancer clinic, we were trying to make better decisions and more efficient decisions about who should have their kidney removed as part of the initial management of their kidney cancer clinic. But the management of kidney cancer has changed dramatically, even just in the last 2 years. And Dr. Tykodi is going to talk to us later today about what's called adjuvant therapy. And so now, if you are a new patient calling into our kidney cancer referral center, if you have not just metastatic or stage 4 kidney cancer, but if you have what appears to be stage 3 kidney cancer or a large kidney tumor, we're often routing you toward our kidney cancer clinic as well, because many of those patients are best treated not just with surgery, but with a combination of surgery and medical or systemic therapy. So it's sort of a broader indication for patients to be seen in our KCMC. And I think a great question is what happens, in this clinic? So how do we navigate patients through the clinic? Well, in that first hour, you're seeing just one of us. And what we're trying to do is get details on your history, do a thorough physical exam, understand your goals of care, and understand, what we hope to achieve by helping you be seen in a kidney cancer clinic. And then we have a very thorough tumor board discussion, which I'm going to talk a little bit about on the next slide. And then in the final 2 hours of the kidney cancer clinic, you meet with the various specialists. So if you met with Dr. Tykodi first, you'll meet with me in that third and fourth hour. And the goal is that you leave this kidney cancer clinic with a concrete plan of care. And so, you're able to start, the journey of your kidney cancer treatment, whether that's with one treatment or a combination of treatments. And so, after kind of a thorough discussion, a thorough review, and meeting all the specialists involved in kidney cancer, you leave with a plan. And I always say, gosh, it's always better to have, 4 or 5 big brain people thinking about what the best thing is for you than just one. And so, rather than sort of a TBD plan where you're saying, gosh, I need to wait and see how your visit with Dr. Tykodi goes, you get to see both of us in one sitting. And this is that tumor board discussion. And you can see the group of individuals that's involved in talking about these cases. This was our KCMC this last Thursday. And in this tumor board review, a really critical part is that, we don't sort of take as gospel the reports of the images or the pathology that come in with the patients with KCMC. We always do a secondary radiology review, and we always do a secondary pathology review. And that's a standard part of being seen at our cancer center. And we have some data on how critical that has been to decision making on behalf of our patients. And some key things we discuss in this tumor board review are, what's the role of surgery and radiation, usually in combination with medical therapy? What patients should be evaluated for genetic risk for kidney cancer? What patients are interested in nutritional support? So we really try to come up with a bullet point specific plan for what comes next for each patient that comes in the door. So why is something like a KCMC really critical? Well, what we have found is that about 1 in 6 patients during that radiology review actually have a change either in sort of the staging of their cancer, the diagnosis itself, or some change that impacts their treatment plan. And I think what a lot of people think about when we show this data is they think that this is typically a change for the worse. So, for example, we find upon our review that there may be more extensive cancer than was previously thought. But we actually have the opposite happen quite a bit, where a patient presents to us for a concern for metastatic kidney cancer, but upon our secondary radiology review, we actually are not quite sure that's true. And some patients are found in actuality to have localized kidney cancer that can be managed with something like surgical treatment. And so these are pretty profound treatment changes that happen about 1 out of 6 cases that are reviewed. And similarly, one benefit of being seen in our cancer center is that the radiologists who are looking at your x-rays are experts in kidney cancer and have an extensive amount of experience looking at CT scans and MRIs in patients with kidney cancer. And very similarly, the pathologist who guides our kidney cancer tumor board every Thursday is an expert in kidney cancer and is involved in national and international guidelines in kidney cancer histopathology. And so that expert review has been shown to change someone's diagnosis that impacts their treatment, again, about 1 out of 6 cases, so about 13% of the time. Why also is something like a kidney cancer multidisciplinary clinic important? Well, we also have some data that's shown that it's associated with a shorter time to treatment. And that makes a lot of sense. So if you are trying to see, one doctor one day and another doctor the next day, and then those doctors have to talk about what the plan should be, getting those doctors in one room together makes for a more expeditious treatment planning situation, and that allows you to start treatment, whether it's scheduling for surgery, whether it's scheduling for systemic therapy. And so we found that our times to treatment were dramatically shorter in patients that we're seeing in our kidney cancer multidisciplinary clinic. And we are constantly evaluating who we see and how we see those patients in our KCMC. So we have sort of the nimbleness to evolve and adapt to things like, having an open clinical trial for whom, patients would need to see surgery and need to see medical oncology. We can change our inclusion criteria for KCMC to adapt to that. And there have been some pretty profound changes in how we manage kidney cancer that impact not only kind of what the outcomes are for patients that come to our KCMC, but how we think about who best is served, who is best served by coming to the KCMC. So for example, when we started the kidney cancer multispecialty clinic in 2017, most patients with metastatic kidney cancer were getting scheduled for what's called a cytoreductive nephrectomy, where we were taking out their main kidney cancer in their kidney prior to starting medical therapy for their kidney cancer. And in July 2024, in part, as Dr. Braun noted, is because we have much more effective therapies. Fortunately, we have much more effective therapies for our stage 4 kidney cancer patients. And now we have flipped that. And the primary therapy that we usually start with is systemic therapy. However, these patients still sometimes have surgical needs. It's just in more of a deferred way rather than an upfront way. There have been other evolutions. So in 2017, someone who had an aggressive localized kidney cancer, these are patients in whom their CT scan did not show any evidence of cancer spread out of the kidney. And Dr. Tykodi is going to talk about this more later in our symposium. But we know that there can be microscopic disease that could grow up as a new tumor later in their care. And it makes a lot of sense that treating those people up front before those microscopic deposits can grow into something that would be clinical stage 4 disease should conceptually have benefit. Unfortunately, in 2017, we just didn't have any options for how to treat it. And in 2024, we do. So now we know that some of these patients who seem to have localized kidney cancer, albeit a big tumor or a tumor that has some aggressive features like invading the vein that drains the kidney, we now have an option for treating those patients that makes their cancer outcomes better. So those patients are better served by being seen in our kidney cancer multispecialty clinic rather than just being seen by a surgeon. And also similarly, we have traditionally thought of radiation therapy as not having a huge role in the management of localized kidney cancer. Radiation has a long-standing role in helping patients with metastatic kidney cancer, whether they have cancer that has spread to the bones that causes pain, which benefits greatly from radiation therapy, or certain sites of cancer spread that benefit greatly from radiation therapy, but it has not traditionally had a role in managing tumors in the kidney. And now there's an emerging role for a type of radiation therapy called stereotactic body radiation therapy in managing localized disease. And so we're sending more and more patients, not for surgery, but to the radiation therapy doctors to manage localized kidney cancer with radiation. So across all 3 of our domains, surgical care of cancer, medical care of cancer, and radiation care of cancer, we're seeing these evolutions that highlight the need for multidisciplinary care and a home for getting patients into our system like the KCMC. And so with that, I'm happy to take any questions. And I see some questions also from the chat that I'm happy to review. One question, I didn't see, did Dr. Braun get to this question about contrast media nephrotoxicity? I don't think he addressed that.
No, we cut off. So that question and the one after it are new post his talk.
Yeah. So, one thing we do think about when we take out someone's kidney is what is the impact on the other kidney? Hopefully everyone who loses a kidney has a good contralateral kidney or remaining kidney. At this symposium, we have at times had a wonderful talk by a nephrologist named Dr. Kim Muzinski to talk about kind of overall kidney health. One really fortunate thing about imaging for kidney cancer is that most contrast media is safe. If someone has a remaining kidney that has some dysfunction, where we worry about the strain on that kidney of the contrast media we will use in a CT scan, We can either do things like pre-hydrating patients. There's some newer contrast media that is less injurious to the kidney, or we can get MRIs. And the contrast media that we use with an MRI typically is very safe to give, even in patients with severe chronic kidney disease in that remaining kidney. So in general, we can figure out a safe way to both, image the kidney, but also, protect the remaining kidney. The next question is that radiation therapy is the primary therapy for attacking tumors directly. Histotripsy is a new treatment being used in liver cancer and tested in kidney cancer. My view on this therapy is really optimistic. So one thing for everyone here to know is that actually one of the, and this is not an exaggeration, one of the international leaders in histotripsy is a urologist named George Shade, who is on our faculty. And Dr. Shade has a lab that is specifically studying the use of histotripsy to treat prostate cancer and kidney cancer. And so for those of you who've never heard of histotripsy, there's a technology called focused ultrasound. Sometimes you might hear it called HIFU, high intensity focused ultrasound, that uses changes in how we deliver ultrasound to tissue that, rather than bouncing back and giving us a diagnostic picture, actually cause tissue damage. But the problem with some traditional ways of doing focused ultrasound is that it also can cause heat transfer, and heat can cause damage to other tissues around your target area. And so, you might treat the cancer, but you might cause an innocent bystander effect. And histotripsy is a way of delivering focused ultrasound that's non-thermal, so it doesn't cause heating. So it creates these really discrete ablation zones. And we're incredibly optimistic for that as a potential technology, mostly for small renal masses. The next question is, does removal of a large kidney tumor when there's extensive metastases help reduce the progression of future growth of other lesions? So that's a question that we thought we had a good answer for in the setting of our older treatments. So it used to be that some well-done clinical trials showed that taking out that large kidney tumor did have benefit for someone's overall cancer care. There are a number of different potential mechanisms for why, but it seemed like that was a benefit. Part of the problem back then, though, was that the medical therapies we had for metastatic kidney cancer just didn't work as well. And so part of it was we were trying to do everything we could to give someone, a longer survival or a longer response to treatment. And now the medical therapies we have are stronger. We do know that people that have a complete response to treatment, sort of the home run that Dr. Braun was alluding to, have all had their kidney removed. And so we do know that taking someone's primary kidney cancer out is part of shooting for what we call an NED state, or a no evidence of disease state. But there is a trial ongoing that looks at starting everyone on medical therapy and figuring out if taking out the primary kidney tumor in sort of a deferred fashion does improve things like the progression of the future growth of other lesions. And so we'll have some better answers in the context of the currently available medical therapies for kidney cancer very soon.
Let me ask you before you go, since we have a surgeon here with us, a question I sometimes encounter if I see a patient that's newly diagnosed and has their kidney tumor in place and I'm sending them to see you, is they ask me, is this going to be something that can be done by a laparoscopic minimally invasive procedure or not? And, I guesswork for me. Is there a rule of thumb? What are the boundaries of being able to offer or not offer a minimally invasive approach versus a conventional big open surgery for kidney tumor surgery?
Yeah, that's a really great question. I think what we aspire to as surgeons is we aspire to being someone that has multiple tools in our toolbox rather than, one hammer we try to use for every nail. And so as Dr. Tykodi knows, I do a lot of minimally invasive surgery, but I do a lot of open surgery. And so we try to tailor the surgery to what we can do safely and what offers us the best opportunity to do an excellent cancer surgery, but in a way that helps people with their quality of life. And so the bounds that I think about in terms of selection for minimally invasive treatment, whether it's a laparoscopic or robotic surgery, one of them is sort of the size of the tumor. So the tumor has to be less than about 13 centimeters in size. And that's honestly just because bigger than that, and the incision you have to make to take it out is the same as the incision you would have to make to do an open surgery. So we're not really benefiting that patient from a quality of life and recovery standpoint. And then we need to think about what the extent of the tumor is. So if a tumor is invading the vein, draining the kidney, if that tumor clot or cancer clot is going all the way into the main vein that takes blood back to the heart, that's a very hard thing to do minimally invasively. And I think it pushes the boundaries of safety. And so those are cases that we tend to do open. Similarly, if someone has other disease around the kidney, like enlarged lymph nodes or an enlarged adrenal gland metastasis, sometimes that pushes us to more strongly consider open surgery rather than minimally invasive surgery. But I will say one change in myself since 2017 is my degree of aggression in trying to get people through minimally invasive surgery, just because I bear witness to how much better it is for their recovery.
Excellent. Well, thank you, John. I think from the provider standpoint, we really value the KCMC and enjoy seeing our colleagues in person and working together on the care of a patient. So it's hopefully the patients find it valuable, and from the provider standpoint, that's one of my favorite events of my work week, is to be able to see a case with my colleagues and come up with an overall plan. Well, let's move forward. Our next speaker is one of my medical oncology colleagues, Dr. Lisa Tachiki. She's a provider here on campus, seeing patients with both kidney cancer and melanoma in our program. An assistant professor at Fred Hutch and at the University of Washington. Lisa was motivated to be able to participate today, but had a conflict and can't be here in person. So she's actually recorded for us her talk. The title is Updates in Metastatic Advanced Non-Clear Cell Renal Cell Carcinoma. So if I can get help from Ritu to launch that, and we'll see her talk.
Good morning, everyone, and thank you to the organizers for inviting me to speak today. Regretfully, I can't participate in person this year, but I'm hoping to make it in person in the coming years. The title of my talk today is Updates in Metastatic or Advanced Non-Clear Cell Renal Cell Carcinoma. These are my disclosures. So renal cell carcinoma is the term that we use to describe the most common type of cancer that comes from the kidney. And we classify different subtypes of renal cell carcinoma in the pathology lab. So either we obtain a biopsy of the tumor, or the tumor itself can be removed at the time of surgery, and we look at this tissue under a microscope. A pathologist should be reporting what subtype of renal cell carcinoma a tumor belongs to. And the most common subtype of renal cell carcinoma is clear cell. Almost 80% of patients with renal cell carcinoma, or RCC, have clear cell histology. That means that 20 to 25% are classified into a category that we call non-clear cell renal cell carcinoma. And the most common of these variant histologies include papillary and chromophobe, which are the two top listed here. Other more rare types include translocation renal cell carcinoma, which occurs more often in younger patients. So as you can see from this list here, this category of non-clear cell is really a heterogeneous group of cancers that encompass multiple histologies with different molecular or genetic features. And the global classification of these tumors continues to be updated and continues to evolve as we improve our understanding of the biology of these different subtypes. Therefore, the way that we treat many of these different histologies is also starting to become more nuanced. So to better understand some of the more recent developments in non-clear cell RCC, I want to briefly describe the background context of treatment in this disease. Targeted therapy has been the standard of care in advanced renal cell carcinoma for over a decade. So what is targeted therapy? This is a term that refers to anti-cancer therapies that work to inhibit activities that drive the growth of cancer cells. So in particular, some targeted therapy drugs block kidney cancer by blocking the growth of blood vessels that supply the tumor with essential nutrients. Other drugs target proteins that are made within kidney tumors that allow them to grow and spread. For a decade, the standard was sunitinib, which is a type of targeted therapy, and that has recently been replaced with a newer iteration of targeted therapy called cabozantinib. So how did cabozantinib replace sunitinib as the standard of care? This was related to a clinical trial called the PATMET trial, which was a study involving 147 patients specifically with papillary renal cell carcinoma. And those patients were randomized to be treated either with sunitinib, which was the prior standard of care, or to 3 additional newer targeted therapy agents that bind specifically to the MET receptor. During the course of the study, crizotinib and savolitinib groups were both stopped early because we did not see clinical benefit to treatment in those 2 categories. However, sunitinib and cabozantinib was able to be completed as planned. And at the end of the study, they found that this newer targeted agent, cabozantinib, showed a higher proportion of patients had their cancer shrink compared to sunitinib, which is described in this objective response rate category in both of these 2 types of papillary. And we also saw that their disease was stable for longer with cabozantinib compared to sunitinib, which is described with this progression-free survival outcome. Therefore, this study was the first randomized trial specific to metastatic papillary renal cell carcinoma that showed a clinically and statistically significant benefit over the standard of care. Following the establishment of cabozantinib as an effective treatment for papillary cancer, oncologists at Memorial Sloan Kettering, which is a cancer center in New York, then evaluated this drug in combination with a drug called nivolumab, which is a type of immunotherapy. So immunotherapy works by a very different mechanism, and it works by stimulating the body's own immune system to attack tumors. So in this schema here, we see that cancer cells are able to grow because they're able to interact with the brakes of the immune system, which therefore inactivate a T cell from fighting the tumor. However, these immune checkpoint inhibitors, which are a type of immunotherapy, are used and they bind to the brakes of the immune system, so that way it shields the tumors from being able to interact with the brakes. This then allows the T cell to be reinvigorated, recognize the tumor, and fight off the cancer cell. So this class of drugs has dramatically improved outcomes for many patients in a variety of cancer types, including clear cell renal cell carcinoma. So for example, nivolumab in combination with cabozantinib have demonstrated good results for patients with clear cell renal cell carcinoma. So this provided an opportunity to study this combination in non-clear cell renal cell carcinoma. And so this study evaluating the combination of nivolumab and cabozantinib in non-clear cell RCC enrolled 47 patients at Sloan Kettering. They divided the 2 cohorts of patients by subtype, so those with papillary unclassified or translocation were enrolled in cohort 1 for a total of 40 patients, and cohort 2 included chromophobe patients, which had 7 of them. And so this figure here represents results from this study at Sloan Kettering, where we are currently evaluating the percent of tumor shrinkage from baseline to kind of the maximal depth of response for each of these patients. And so each bar represents a single patient. So this long blue bar here represents a patient with papillary renal cell carcinoma who had 100% shrinkage from the combination of nivolumab and cabozantinib. And subsequently, each bar here represents a different patient. The dashed line here represents a 30% threshold, which is the threshold that we use to say that someone had a significant response or a partial response to treatment. So you can see that in the first cohort that a significant proportion of patients did have shrinkage of their tumors to some extent. However, you can see in cohort 2 that in patients with chromophobe renal cell carcinoma do not show the same degree of tumor shrinkage that we are seeing in cohort 1. So the objective response rate in this cohort was 0%. Altogether, though, this was the first study to demonstrate that the combination of targeted therapy and immunotherapy in non-clear cell RCC, specifically in papillary RCC, may be a quite promising treatment option. So following the combination of cabozantinib and nivolumab was another larger study in non-clear cell renal cell carcinoma called the Keynote B61. And this is a study that evaluated the combination of immunotherapy drug pembrolizumab with a newer targeted therapy agent lenvatinib in non-clear cell renal cell carcinoma with a total of 158 patients enrolled. So there were multiple histologies enrolled in this study, including 93 patients with papillary and 29 patients with chromophobe renal cell carcinoma. So of note, this is one of the largest groups of papillary renal cell carcinoma patients that has been enrolled. So here we see some of the significant results from this study. What we are looking at are objective response rates, meaning what proportion of patients in each of these cancer subtypes actually show significant shrinkage or response from the combination therapy. And what we can see is that overall about 50% of patients had an objective response to therapy. In papillary renal cell carcinoma, we see almost 11% of patients actually had complete response. Basically, their scans do not show evidence of disease because of the significant shrinkage. 43% of patients had partial responses in this cohort. Similarly, in unclassified and in translocation, you see 50% or higher response rates. Interestingly, in the chromophobe subtype, you see a significantly lower response rate, which demonstrates that chromophobe does not appear to be behaving in the same way as these other subtypes. This graph, just like the nivolumab cabozantinib study, shows the depth of tumor shrinkage, which is represented as the percent change here on the y-axis again. So what we can see is that in the papillary cohort, which is represented by the green bars here, we see a good proportion of patients with shrinkage, and you actually see patients, significant amount of patients with 100% shrinkage. And if we compare that with the chromophobe histology, we do see that there is some degree of shrinkage, but not to the same proportion or extent that we see in the papillary. And then this is another outcome from the study. We're looking at progression-free survival and overall survival. And these curves represent outcomes that we care a lot about because they demonstrate, one, how long can patients live without their cancer getting worse on the left here, or two, how long do patients live overall after getting treatment. And what we can say is that the median progression-free survival, which is defined as the time it takes for half of the patients in the study to have their cancer progress, was about 17.9 months in this cohort. In comparison, when we talked about the cabozantinib alone study, that progression-free survival was 9 months. Similarly, in the overall survival outcome, we have not actually seen that half of patients have passed from their disease related to taking this treatment. In comparison, the median overall survival in the cabozantinib study was 20 months. Taking a look at the safety profile or side effect profile from this combination, we see that the most common side effects include high blood pressure, diarrhea, hypothyroidism, protein in the urine, and fatigue. These are pretty anticipated side effects from either targeted therapy or immunotherapy. As one may anticipate, the combination of these two classes of drugs unfortunately confers a higher risk of side effects compared to either of these drugs alone. The rate of serious side effects or side effects where we have to take significant clinical action to try to reverse some of the side effects was about 40%, with about 20% of patients who discontinue pembrolizumab and about 20% of patients who discontinue lenvatinib. So in particular, what we also want to look at are these immune-mediated side effects. In particular, pembrolizumab can induce excitement of the immune system to help recognize the tumor and fight off the tumor. But sometimes the immune system can get overly excited and try to cause autoimmune side effects as well. And so the rate of needing steroids to try to resolve some of these side effects and therefore calm the immune system down is pretty in line with what we anticipate for Keytruda, with a rate of about 14%. In summary, Keynote B61, using that combination of lenvatinib plus pembrolizumab, has been the largest single-arm study to date that has enrolled non-clear cell renal cell carcinoma. And this has generally changed oncologist's approach to treatment in non-clear cell renal cell carcinoma. Many oncologists will use lenvatinib and pembrolizumab based on this data, especially when thinking about papillary renal cell carcinoma patients. It's important to note that in chromophobe, we did not see the same sort of degree of response to the combination of immunotherapy and targeted therapy, though we did see some signal of efficacy there. So some of us will use instead the combination of lenvatinib and everolimus. So we draw from data from a phase 2 study published in 2021 that evaluated the combination of lenvatinib and everolimus in 23 patients who had non-clear cell renal cell carcinoma. Each of these drugs alone, lenvatinib and everolimus, have historically been used in renal cell carcinoma, but it was the combination that was the novel intervention here. And we see that in this cohort, the objective response rate was about 26% with manageable treatment-related side effects. But what's important to note is that they enrolled 9 chromophobe patients. And so we actually see 44% objective response rate with a proportion of patients that had a pretty significant depth of tumor shrinkage from this combination. And so it's possible that chromophobe renal cell carcinoma may not be as responsive to immunotherapy, but does appear to be responsive to this targeted therapy combination. And therefore, we place this combination higher up on our preferential list of active treatments for chromophobe renal cell carcinoma compared to other historical treatment options. So some of the high-level takeaways that I would like for us to take away from this talk today are that 1, histologic diagnosis, either obtained from a biopsy or from a surgical specimen, is key in order to inform the subtype of renal cell carcinoma that we have at hand and to inform treatment recommendations. Due to the rare nature of these variant histologies, it's worthwhile for a patient to get a second opinion at a center that sees a large volume of these variant histologies, therefore meaning getting a consultation with an RCC expert and considering clinical trials when appropriate. Most non-clear cell renal cell carcinoma studies, as you may have seen from this presentation today, lump all different subtypes of renal cell into basket trials. Therefore, there's ongoing momentum to focus on collaborative, multi-institutional efforts to bring histology-specific clinical trials to our patients. Fortunately, there are 3 trials that I've listed here that are ongoing, looking at patients with specifically papillary renal cell carcinoma. While there is ongoing momentum for enrolling patients in papillary-specific studies, we need to be able to do the same for other non-clear cell subtypes. We need to be able to do this for chromophobe renal cell carcinoma. I think in the interim, it's reasonable for us to consider the data that we have at hand, which often supports lenvatinib-based therapies. Keynote B61 with a combination of pembrolizumab and lenvatinib demonstrated an objective response rate of about 30% in a cohort of 29 patients with some degree of tumor shrinkage in many of those patients. We will often favor the combination of lenvatinib and everolimus based on the phase 2 data that I showed to this group here, with a cohort of patients demonstrating a good depth of tumor response from the targeted therapy combo. Keynote B61, again, that pembrolizumab and lenvatinib combination, does show compelling early results for many of these non-clear cell subtypes, so longer-term follow-up will help us delineate the durability of these responses and what overall survival looks like from this clinical trial. I think another important exciting direction for the non-clear cell space is the idea of utilizing next-generational sequencing to look for mutations in these different tumors. So that way we're not just classifying non-clear cell by their histologic subtype, but also directing treatment based on their genetic mutation profile. For example, the SYMETA trial is evaluating patients with papillary renal cell carcinoma who have specifically MET mutations, and they're receiving treatment that targets the MET mutation. So the hope here is that our implementation of practices like next generational sequencing increases, we will be able to better tailor our treatments for patients in a category of RCC that has historically been harder to treat. Therefore, a lot more to come in non-clear cell RCC in the coming years. And this concludes my talk today. Thank you again for the opportunity to share some information on non-clear cell renal cell carcinoma, and Dr. Gore and Dr. Tykodi will now be taking questions.
So yes, I'm happy to jump in. Obviously, Dr. Tachiki isn't available to answer questions, but I think there's a couple that came into the chat. LB says, my husband had RCC 17 years ago, stage 3, and is doing well. So far, so good. He now has been diagnosed with melanoma. I'm wondering about the connection between the two. It is interesting that our clinical group is the kidney cancer and melanoma clinical team. That being said, neither disease has a high incidence of underlying genetic risk that corresponds. We are always thinking when we see new patients, is this a person that I might refer to genetics? And there are some clinical cues. For renal cell, it's argued to be maybe 5 to 8% of patients that can have a hereditary risk for the disease. And most of the genes that link to increased kidney tumor appearance really don't cross over to other types of cancer. There's perhaps one gene, BAP1, that might increase risk of both diseases, but it's very unlikely that there's some genetic component that corresponds to both diagnoses. There's the chance that there's some underlying illness. It doesn't sound like it from the brief description, but immune suppressive environment, patients that have a solid organ transplant that take chronic immune suppression, patients that have a disease like CLL or a lymphoma that are immune suppressed, have increased risk of certain cancers. That includes both melanoma and kidney cancer incrementally. So there could be a biological component, but most likely there isn't any direct association. And just for interest, you might say, well, why in the world are those two diseases grouped together for doctors at a cancer center? It links back to the older therapies Dr. Braun was talking about. There was a time when the standard drug for both diseases was high-dose interleukin-2, which was very difficult to administer. Patients had to be in the hospital setting. You had to train your care team about how to safely use that drug. And so in that setting, those two diseases would be linked through a single doctor that knew how to supervise the IL-2 therapy. As time has worn on, we don't do much IL-2 anymore, but the newer drugs that we use for both diseases are virtually identical. We use the checkpoint therapy drugs as our priority treatments for both melanoma and kidney cancer. So it still fits together really nicely. There hasn't been a strong reason to pull the diseases apart. Our nurses, our colleagues, our nurse practitioner support team, seeing both diagnoses, sees the same drugs, the same toxicities. They're very savvy at helping us manage our patients, and it cuts across the two diagnoses. And so there's still a lot of overlap. And for the foreseeable future, I think the two will probably live hand in hand on our campus. At other cancer centers, kidney often will get pushed over to the so-called GU oncology group, that doctors that see prostate and bladder and testicular cancers. And so it's conceivable at some point there could be a reorganization. But I think from the perspective of Dr. Tachiki and I, it still works fine to have melanoma and kidney cancer go together. I think that's the last. Oh, wait, there's one more.
I can tackle this one if you'd like, Dr. Tykodi.
Sure, yeah.
So the question is, with all this new research happening in papillary RCC, should a patient undergo surveillance, before having some form of surgery, thinking that new treatment options may be available in a number of years? And, there is a potential future state where kidney cancer is treated medically and not surgically, but we're definitely not there yet. I would say this just depends on the characteristics of the tumor. So whenever someone meets me in clinic with a localized kidney tumor, we always talk about how the decision-making relies on the characteristics of the tumor and the characteristics of the patient. And if the tumor itself has some features that make us worry that waiting could be risky, and threaten the possible spread of the tumor, then it just wouldn't be appropriate to wait. If, however, it's a situation where someone would be a candidate otherwise for surveillance anyway, and we know that's a safe thing to do, and one of our keynote speakers, Dr. Pierorazio, is going to talk about that here in a little bit, then that's a perfectly reasonable solution. It just really depends on that.
The last comment is a patient with chromophobe and just championing the desire to continue to move the field forward and find new treatments. Excellent. Well, let's move forward and bring forward our next speaker. I'd like to introduce Bryan Lewis. Bryan is the president and the co-founder of KidneyCAN, a nationwide kidney cancer advocacy group. And so, Bryan.
Great. Thank you, Dr. Tykodi, and thank you, Dr. Gore, for this opportunity. I just want to make sure that I'm sharing my screen correctly. Can you confirm that I am? I know, Dr. Tykodi.
We don't see your share yet, Bryan.
Nothing yet? Okay, let's try this again. Sorry. How about, let me try it. Sorry. My children call me a boomer for a certain reason. I think this is it. See if I can get back to the beginning here. Sorry about the delay. Okay, let's try that. And then give me one more second.
Nothing yet. Does it show sharing on your side?
Yes, I'm just trying to get back. I was in my PowerPoint and my screen froze on me, so I'm trying to just get myself back over to the. Here we go. Let's try this. How about now? Any better?
There we go. Yeah, perfect.
And okay, let's see. Why won't I see this on my screen? Okay, well, apologize for the technological challenges here. I'll see if I can manually do this. I usually get help because of exactly these reasons. Yeah, now I'm not able to forward my slides. Give me a second. Let's see if I can. How about now? Any better?
Yeah, you've moved ahead to your second slide.
Okay, sorry about this. I don't know. I seem to have some slowdown on my side. So anyway, my name is Bryan Lewis. I'm the president of KidneyCAN. When I first started KidneyCAN with the NAPS, who you'll hear about in a minute, it was 2018. I was diagnosed with metastatic kidney cancer in 2007. Was surgically resected at the NIH in Bethesda, Maryland. And I'll tell you my story along with KidneyCAN's story. Here's some disclosures just to let everybody know that KidneyCAN gets support from industry, from pharmaceutical companies, but also from hundreds of kidney cancer patients and family members across the country. I serve on the NCCN guidelines panel, as well as the external advisory board for the Kidney Cancer Research Consortium, and I'm also on the board of directors of the Kidney Cancer Coalition. Today's topics, I only have a few minutes, so I'm going to go really fast. I'm going to talk a little bit about KidneyCAN's mission, but I'm also going to talk about supporting patients and then come back to our advocacy efforts, which sort of distinguishes us as a patient advocacy group. In 2016, I met with Ralph and Brendan Knapp, who were doing some fundraising for clinical trials. I was living in Washington, D.C., doing advocacy on Capitol Hill. We met and decided to join forces to try to change the landscape of the kidney cancer research community. And so this is a circle that we talk about regularly at KidneyCAN, and you can see there's multicolored sort of stripes to the circle. The first one we start with is awareness. KidneyCAN is not really, even though it's in the top 10 cancers that are diagnosed in the United States, not really well known. So building awareness is one piece of this puzzle. We believe that raising awareness gets people excited about doing something, and we focus on advocacy, and we'll talk a lot about that at the end here, on the efforts of bringing the message and the education around what goes on with kidney cancer to our congressional leaders, and see if We believe that that advocacy then leads to funding, which I'll talk about here in a minute. And that funding ultimately will push towards research that a lot of folks like Dr. Braun and Dr. Tykodi and others have seen, the research funding that allows them to explore these next breakthroughs, and ultimately feel like the research is going to lead us towards the cures. And as you saw from Dr. Braun from 2005 or 7, when we first had IL-2 and sunitinib, then to immunotherapy in 2015. Now in 2024, we have belzutifan and other things, and more things coming down the road, as you see. So all of this takes, unfortunately, time, but it also just takes efforts, ongoing efforts by all of us. I'm going to fast forward to what we do, and Amy from the KCA is going to talk to you much more in depth. KidneyCAN was started around advocacy in Washington, D.C., and we found out that a lot of patients who have been just recently diagnosed, they don't really care that much about advocacy. They want to know about their health situation. So we've created on our website some patient education and support efforts. The KCA does a wonderful job. It has a lot of resources. We decided not to recreate those, but just try to bring together the best. So you feel free to look through our website and get some access to resources. We also do what's called a town hall series across the year. We have 3 of these on different topics, talking about immunotherapy, or every year we do a looking back at the research from that year and then looking forward to what's coming down the road. Keep an eye out for those on our website. We also do an educational support series with the National Kidney Foundation on a variety of topics and some of the correlation between kidney disease and kidney cancer. And we're big fans of Smart Patients. If those out listening haven't heard about Smart Patients, highly recommend. It's a closed community that you have to be invited to be a part of if you are, part of the kidney cancer community. And then you get to talk privately about all kinds of topics. Couldn't more highly recommend that as a community if you have an opportunity. But let me focus on advocacy, because that's what KidneyCAN is really all about. And if you ask yourself, how does research happen? How does kidney cancer research happen? Well, it takes people, and we know that. It takes a lot of people. But it also takes a lot of science and a lot of money. And if you look at the efforts that go into an FDA new drug approval, sometimes it could take 7 to 10 years. I mean, the amount of basic science to the bedside, to clinical trials, and then approvals, it could take quite a bit of time. And as we've seen, that takes a lot of money. And so when we first got started, and I was starting to go up on the Capitol Hill and talk to people, we realized really quickly that kidney cancer is terribly underfunded. And so you can see, this is an American Cancer Society data from 2018. Kidney cancer was getting about 13 of the awards, compared to, say, breast cancer, which was getting 162. So we knew there was a problem in terms. But we decided that if we could get people talking, come to Washington, D.C., talk to our elected representatives, we could do something about that. And so over the past 8 years, we've had more than 1,600 different congressional meetings and trying to build champions on Capitol Hill around this medical research funding. And we're very fortunate in what was called FY, fiscal year 17, to get $10 million dedicated for kidney cancer research. And so we got that $10 million, and the first awards were starting to be given out, and we grew that the following year to 15, and then to 40, and now we're up to $50 million annually. So every year, Congress has to appropriate that money. It's not an annual evergreen piece of legislation. The Congress has to say that they would like this money dedicated to kidney cancer and other research projects. And so we have to go back every year and ask, and we have to get people in the House and the Senate to be supportive of that. We've gotten $50 million, and we're very proud of that. We're thankful for that, but we've got a ways to go, and we could use your help, and we'll talk about that in a few minutes. Many people maybe on this call have already been helping, and some of our doctors here on this call have been helping. We really appreciate it. So the question then becomes, so what? So what does that mean? You got some money, great, good job. Well, we early on realized that when we were talking to these folks, these doctors that were getting the research funds, that they weren't necessarily talking to one another. And that wasn't intentional. That's because when you do research, you go into your laboratory, you put your head down, and you do what you have to do to find the outcomes. And so KidneyCAN, with some other folks and some industry representatives, as well as private funding, we decided to do something about that and bring those people together that were winning these awards so they could talk to one another. And so KidneyCAN, we created what's called the Kidney Cancer Research Summit. We just held our 6th one this past month in Boston. We brought together a number of kidney cancer researchers from around the globe and let them share what they've learned and what the research is uncovering for them. And so we're making progress. We've grown to 235 million in funding overall. We have this grassroots army of hundreds of people. We've had over, as I said, 1,600 congressional meetings. But we've got work to do. As you all know, there are 82,000 new diagnoses this year for kidney cancer in the United States, with 15,000 people passing away. And the funding gaps are unacceptable to us in the patient community. And so I don't know if this will play, but I want to play a quick commercial. I hope this will play for you all. Is it playing, Dr. Tykodi?
KidneyCAN's a nonprofit organization with the mission of putting an end to kidney cancer. We want to accelerate a cure, and we do that by focusing on advocacy, research, and patient education. Advocacy Day is our attempt to bring people from across the country, a small grassroots army, if you will, of kidney cancer stakeholders, and we bring them together, we train them, and we talk about the issues, and we all go up to Capitol Hill and meet with our elected representatives.
What we want to do is not only just raise awareness, but raise the funds for research.
It is an opportunity for someone to, at a higher impact, talk with congressmen, senators, and their staff in regards to funding for cancer research, specifically kidney cancer research.
While this year will look different as we connect via Zoom with our elected representatives, the mission remains the same: to engage and educate policymakers on the needs and the urgency around kidney cancer research funding.
I'm really looking forward, once again, hoping to make an impact in research funding for kidney cancer. And this is one way that I can contribute.
We have found that.
Sorry, I might have accidentally hit the pause button. I apologize for that. Anyway, sorry to cut off the commercial there, but as you saw, this was recorded during the COVID time, and we were having a hybrid meeting with Zoom, and we continue to do that. We have 2 days that are going to be coming up in Washington, D.C., September 23rd and 24th. And then on the 25th, we have a virtual day where we ask people to dial in from around the country. So don't feel obligated to come to Washington, D.C., but if you could go to our website, KidneyCAN.org, you can register, and we'll set up training along with mentors to help you through the process. Just about anybody can go to Washington, D.C. or join on our Zoom call with our congressional offices, raising awareness. It's not hard to do, and we'd love to have you. All the information is right there at KidneyCAN.org. So with that, I believe I just want to say thank you. Thank you, Dr. Tykodi. I'd be happy to stay on and answer any questions.
Well, thank you so much, Bryan, for that perspective, and a personal thank you for what you do. I think as somebody that does kidney cancer research, the DoD funding and the KCRS annual meeting have been, the most impactful things I've seen in my career that have really changed the landscape, I think, of the kidney cancer research world and the community that comes together now for an annual meeting. It's really extraordinary. Excellent. Well, let's bring on the last speaker before our break, Amy Marbaugh, the Director of Patient Programs for the Kidney Cancer Association. Amy.
Great. Well, thank you so much, Dr. Tykodi, Dr. Gore, for inviting the KCA to spend a few moments this morning with all of you to go over some of our patient offerings. I am the Director of Patient Programs at the KCA. I'm also an oncology nurse by background, and so glad to share some information. So the KCA was founded in 1990 by a small group of patients and doctors in the Chicago area, and today has grown into an international nonprofit organization. Our mission is to be a global community dedicated to serving and empowering patients, and we do that through our 4 pillars: support and empower, research, educate, and advocate. So I'm going to go over some of our programs and services that really fall under that support and empower pillar that is really our main patient pillar. So one program that we offer is a patient navigator program. That picture is of Rosemary. She's our patient liaison. And our patient navigator program is a support resource where patients or caregivers or family or friends can reach out to the KCA if they have questions regarding resources or questions about a diagnosis or anything that might be coming up during the kidney cancer experience. And Rosemary is able to provide some resources specific to the needs. If there are clinical questions, I jump in and can provide some information. We always encourage pointing back to your care team for any specific questions, but we do provide some general information. And this service is free. It is available by phone or by online form that you can fill out. You can see more information on our website. And at the end of all of this, I will drop links for all of our programs, but there are QR codes as well if you would like to scan those. We also have a really robust education series. Our flagship patient education opportunity is our virtual patient symposium. This year it will be in September on the 21st, and it is free to register. It's from 11 a.m. to 4:30 p.m. Eastern, so that's 8 a.m. to 1:30 p.m. Pacific time, but it's completely virtual, open to anyone, and you can see on the right-hand side of the screen some of our topics this year. Similar to what we've discussed today. Others are kind of unique, understanding your radiology reports, integrative oncology, optimizing kidney health, talking about the many emotions after kidney cancer diagnosis, and some focus on caregiving essentials, as well as sharing some patient and caregiver stories. We have a Just Diagnosed toolkit. It is our patient guide. It is available for anyone diagnosed at any stage, at any point in their disease, not just those who are newly diagnosed. But it really kind of goes over the basics of kidney cancer, how to find a specialist and how to get an accurate diagnosis, exploring different treatment options, side effects, and then, of course, finding support and resources. We have a lot of digital tools on our website. We have a clinical trial finder and a treatment center finder. The clinical trial finder takes information from clinicaltrials.gov, which houses all of the clinical trials that are available for any diagnosis, whether it's a kidney cancer diagnosis or anything. But our website takes that information from clinicaltrials.gov and brings over the most important information that patients and caregivers need to be able to find clinical trials that they may be appropriate for, that may work for them to then take that information to their doctor. And that tool is updated monthly with all new trials that are coming out. Our treatment center finder provides a robust list of physicians throughout the country who treat kidney cancer, as well as the centers. And so both of those tools are on our website, and again, should be easy to use and navigate. And then in the middle are financial assistance, our patient assistance fund. This is a fund that provides $250 gift cards to any kidney cancer patient who is in need of financial resources due to their kidney cancer diagnosis. You don't have to show a proof of financial hardship. You just need to kind of outline, the types of expenses that you're experiencing due to your kidney cancer, directly due to your kidney cancer diagnosis, and you're eligible. Your care team does need to fill this out. So you would need your nurse navigator or a social worker to fill that out on your behalf, but otherwise that $250 gift card can really go a long way to helping pay for copays or prescriptions or surgical costs, things like that. We have a lot of psychosocial supportive resources. We have a place on our website that we call our honor wall. That is a place where you can share your kidney cancer story or that of your loved ones, just to kind of, provide support to others and kind of honor those yourself or anyone going through a kidney cancer diagnosis. Bryan already touched on smart patients. We at the KCA are very big believers in the smart patients community as well. And so we have we do promote that. We also have a Facebook community that you can find on our website as well. And we also offer 2 different virtual support groups. So one is patients specific or patient perspectives, and that meets on Wednesdays, on the last Wednesday of each month. And then we have our caregiver connections, which meets on the last Tuesday of the month. But those are open and to anyone, patients. The patient one is patient specific. The caregiver one is open to loved ones and caregivers specifically. But and those are drop-ins. You can join 1 month, whenever you're available. So always available for you each month. We also offer a peer mentoring opportunity through one of our partnerships with Immerman Angels. Immerman Angels is a organization that helps to match patients, a kidney cancer mentor, someone who has gone through the kidney cancer experience, with someone who might be newly diagnosed or have a recurrence. And so anyone who's looking for a mentee looking for a mentor. And lastly, we're really, really excited about this. We launched a podcast earlier this year for patients and caregivers. It's called Kidney Cancer Unfiltered. It is a look at just different patient stories, and we have some experts as well sharing some insights just about a variety of different topics surrounding kidney cancer. Season 1 dropped earlier this year, and we are currently recording season 2, and those episodes will drop in the fall. But if you ever would like to join us on the podcast and share your story, please feel free to reach out. We are happy to take all kinds of guests to share their stories. We have a really robust awareness campaign. Bryan kind of touched on this with respect to bringing awareness regarding kidney cancer. So if you don't know, Kidney Cancer Awareness Month is in March. And so with the KCA, we encourage people to light up their cities orange for Kidney Cancer Awareness Month. And so I'm not sure if anyone has ever done that for Seattle or the surrounding area, but we'll have information on our website later this year about how you can light up different buildings or events in your area to orange just for the month of March to raise awareness. And we also have an 82K challenge. 82,000 patients, as we've kind of discussed today, will be diagnosed in this year in 2024. So the number always changes each year depending on the number of patients who will be diagnosed. But this year is our 82K challenge. We just wrapped that up, but we always have it each year. And so it's just a way to bring awareness to family and friends about kidney cancer, and doing things kind of in the 82 kind of using 82 as a benchmarker. So walking 82 minutes or drinking 82 ounces of water or meditating for 82 minutes, or you kind of get the idea. But we had some regional challenges this year. We had one in the Portland, Oregon area, so coming to the Pacific Northwest. So again, if that's something you would like to bring to your area, there'll be more information on our website later this year. And finally, this is a very brand new program. We've actually not announced this yet, so you all are the first to hear about this. We have we heard from patients and caregivers that they were looking for care packs, items to take with them to appointments, or comfort items, or just things that they might need to use at home, in part due to their kidney cancer diagnosis, or to take with them to clinic, to take notes or something like that. So we put together 2 care packs, one specifically for patients and one specifically for caregivers. And you can see the items there on the screen. So for patients, we have a water bottle, we have a pill dispenser, we have a pack of playing cards. If you have a long wait time at the doctor's office, or if you're there for infusion and just want to spend some time. And of course, a notebook and pen to take notes. For the caregivers, we have a lunchbox so that, bringing drinks or snacks along to treatments, a travel mug. We also have a little kind of art set just to, kind of color or doodle, if it, during long appointments or during stressful times. And of course, also the pen and the notebook. So if you scan this QR code, and like I said, I'll drop the links in the chat here when I wrap up, you can request this care pack. It is totally free. And like I said, you are the first to know about this. We literally just finished creating these items. So we're very excited to bring this to you all today. And like I said, one item per person, but yeah, we are able to ship those to you free of charge. Oops. And you can find us online at our website, kidneycancer.org. We're on most of the social medias, Facebook, Instagram, Twitter, X, whatever, and LinkedIn. And we are just really pleased to join you again today to share some of our resources. And any questions, please feel free to reach out. Thank you so much.
Great. Thank you, Amy, so much. We used to have a local support group that met in person until COVID. And I think, unfortunately, with the pandemic, they have functionally disbanded. So it's wonderful to see the resources that are immediately available in a virtual space. I think people are so much more comfortable in this day and age about how to find things online and virtually. So very good. Well, thank you to all of our morning session speakers. We're at our break. I have 11:10. I think if people can just take a quick 5-minute bio break and grab a snack, and let's log back in at 11:15 and plan to try and kick off the second half of the program close to on time. We'll see you all in 5 minutes.
Us in urology about wellness and well-being. We have a hard time as surgeons caring for our patients if we don't do a good job caring for ourselves. So I am inspired by Dr. P to do a better job caring for myself so I can care for everyone participating in this symposium. For those of you who may not know, Dr. Pierorazio is coming to us on call. So he is balancing giving this talk for us in between taking care of patients with urgent needs. So thank you so much, Phil. And it's really a pleasure to have you on the symposium.
John, thanks for the wonderful introduction. You didn't need to say so much, but I appreciate you doing it. Scott, thanks for having me as well. And Bryan and the KCA, another great meeting. I'm sorry I missed you guys in July in Boston, but I'm super excited to be here. And I was really excited to see all of the great initiatives you guys are having. I will add a lot of those links to our websites to make sure our patients here on the East Coast can see those things as well. I think they're super, super helpful. As you know, it's kind of the first official day of the Olympics. I'm a huge Olympics fan. I will not send out any spoilers other than we have 2 medals already, and the U.S. soccer team is winning 3-0 right now at the half. So things are going well. I am going to get the PowerPoint up and share my slides, and hopefully we can have some fun talking about active surveillance for a little bit. So let's get the share up. There we go. All right, and you guys should see the proper view. Nope, you don't. There you go. How's that, John? Thumbs up? Cool. Okay. Well, once again, thanks for asking me to talk about kidney cancer. And I titled this talk, Why Would I Ever Watch a Kidney Cancer? And we know this. This is why we're having this meeting. Kidney cancer is scary. 200,000 people per year in the world die of kidney cancer, almost 15,000 per year in the US. Why would we ever want to watch a kidney cancer? And this is a disease of huge bookends. And the reason we're having this meeting, and the reason people are aware is because people have been scared to death of it. And yeah, there's certainly 15,000 people a year who will lose their lives to this disease. And that's one end of the bookend. But at the far end are tens, if not hundreds of thousands of people diagnosed with small renal masses, small kidney tumors that may or may not be a kidney cancer that will never affect their longevity. And that's the flip side and the balance. And there's a lot of gray area in between, but these are the two huge paradigm differences we see in the management of kidney cancer. So I'd like to spend some time starting just by talking about the small renal mass. What does this mean for us as urologists, and what does this mean to our patients? So there's a long backstory here in kidney cancer where the number of kidney cancers, this is US data, but we see these numbers around the world. The number of kidney tumors and kidney cancers in the US and around the world have increased dramatically. This graph shows you 20 plus years. It's longer than that. It goes all the way back to the 70s. And a lot of that was driven by initially increased use of imaging. Cough, sneeze, car accident, belly pain, you got a CT scan or an MRI or an ultrasound, and we found a lot of these smaller renal masses. Now there's some other trends, increasing obesity, probably some of the metabolic issues and problems going on in our country and our world, and we're seeing much more of these kidney tumors. But if you notice the bottom line, that's the mortality from kidney cancer, and it really remained flat for a long time. So a lot more cancers, no more deaths. And finally, we started to see some improvements in downshifting in that bottom line with newer therapies for our 14,000 patients with metastatic kidney cancer. Interestingly, the stage distribution, or the kind of tumors we're seeing, also, we saw a huge increase in these early stage kidney tumors. These are what we call stage 1 tumors, and I'll explain what all that means in a second. But now we know 70% of kidney cancers that are diagnosed are stage 1 cancers. These are relatively small tumors confined to the kidney. So just to kind of review stage once again, stage 1 we call localized and small. The survival is excellent. 95% of patients are alive long-term. Stage 2 disease are localized to the tumor, but they're larger tumors, 7 centimeters or bigger. Stage 3, these are locally advanced tumors that are spreading into the regions around the kidney, whether it's by a tumor thrombus or directly into some of the tissues around the kidney. And then stage 4 is obviously metastatic, our most worrisome form of kidney cancer. But as we said, 70% of the patients we're going to see are in this localized small kidney mass range. And so just to put that in context, this is a great figure that many, many people have seen. This just helps us understand the size of kidney tumors and what we're dealing with. So when your doctor or your loved one comes home and says, I've got a 3-centimeter mass, what does that mean? Well, how big is that? We don't talk a lot about centimeters in this country, but 3 centimeters is about the size of a grape. 4 centimeters is a huge cutoff for us. This table and figure uses fruit. My favorite thing to remember, and I actually really don't like golf, but a golf ball is 4 centimeters, and it's really easy to remember. 4 centimeters is this huge cutoff. And we know with kidney cancers, things that are bigger than golf balls, as they get bigger, increased likelihood of cancer, increased likelihood of aggressive cancer, increased likelihood of potentially fatal cancers. But under 4 centimeters, we're dealing with this entity called the small renal mass. And so what is that? Well, the small renal mass is a solid renal mass, less than 4 centimeters, that is suspicious for what we would call a stage T1A renal cell carcinoma. Why is this such an important definition to remember? Well, first of all, by solid, this is not a cyst, and cysts are even more common. There's probably 100,000 people each year in the US diagnosed with a renal cyst, and that's a fluid-filled structure on the kidney. Without getting too in-depth into cysts and what a cystic mass is, the vast majority of renal cysts are benign. They're not even cancer. We don't even think they're cancer. So that's a really important distinction. When they're solid, we're much more likely to be a cancer. And then the other thing we have in here that's really important is that it's suspicious for a cancer. There's some benign entities, one of them called an angiomyolipoma, which we can pick out just by looking at a good CT or an MRI because they have distinguishing features like fat in them. And we know cancers don't have fat in them. So we can't, basically a 4 centimeter mass, golf ball or smaller, we think it's a cancer. We don't know, we're not sure exactly what it is. Why is this so important? Well, actually, even though we think they're a cancer, there's a lot of heterogeneity in here, apples and oranges and everything in between. 20 to 30% of these 4 centimeter tumors or smaller are actually benign tumors, like these AMLs or oncocytomas, things that we can't tell are benign just by looking at them. And most of the cancers are what we call indolent. And that basically means benign behaving. Yes, technically they are a cancer, but they don't behave like a cancer. They have no ability to spread or cause problems. Second, these are incredibly common. There's probably 60 to 70,000 people per year in the United States diagnosed with a small renal mass. That folds in the benign and malignant masses, anything we're worried about being a cancer, but that's almost as many people are diagnosed with kidney cancer in general in the United States. And lastly, we know the outcomes for these patients are excellent. And I'll show you some of the data supporting each of these 3 important points. These data are a little bit older, but this is what's called a meta-analysis. This study, which was done by my former fellows and residents when I was at Hopkins, took data from surgical series all around the world, and they looked at all of the surgically removed tumors. And what you see on this graph, 4 centimeters or smaller, 80 to 90% of the masses that are removed are either formally benign or what we call low-grade tumor, low-grade, low-stage tumors that basically have zero ability to leave the kidney. 5 to 10% of those tumors, sure, they could be potentially aggressive cancers. So if you do the math on this, anywhere between 5 and 10,000 patients are having surgery for a tumor that is never going to affect their longevity or their livelihood. And so we just need to kind of put these things in context. There's been some really beautiful analysis out of the United Kingdom, something called the TRACER-X program, when they looked at the genetics of these programs, genetics of these tumors. And this is kind of a complex figure, but I'll make it really simple for you because I'm a simple surgeon. If you look at the top, these are your stage 1 kidney cancers, and those are a figure displaying the genetics of those stage 1 tumors. At the bottom are stage 4, patients who have metastatic kidney cancer. You don't need a PhD in genetics to understand that the top is a lot simpler than the figures at the bottom. And so genetically, tumors, as they progress and become aggressive and bigger, are a lot more genetically complex. The small renal masses are actually kind of boring from a genetics standpoint as well. And this group did something even more interesting. They kind of traced back the genetic development of these tumors. And it turns out that a small renal mass is actually probably 20 to 30 years old. The first genetic defect in one of the cells in the kidney, loss of chromosome 3p, not that you need to remember any of that, but that's one of the early genetic factors in the development of clear cell kidney cancer, probably happens 20 to 30 years before a small renal mass becomes detectable on a CT scan or an MRI or an ultrasound. And sometimes when I explain this to patients, it helps them understand how indolent or benign behaving these things are. It's been around for decades, maybe as long as since you were a teenager or a 20-year-old, and it took into your 40s, 50s, or 60s for it to become apparent. It's probably going to take a lot longer for it to become an issue. And that brings us to treatment. So we've got lots of treatment options for these masses. So when we think about our treatment options for kidney cancer in general, we're going to talk more about active surveillance. And what I would say right up front, and we'll get more into the data, this is ideal for really small masses, 2 centimeters or smaller. We know up to 4 centimeters for most people, and even some people you can watch masses bigger than that. We watch people with serial imaging. We avoid the operating room and unnecessary treatment, and the risks of metastatic disease and death from kidney cancer are incredibly rare. We know we have 2 nephron-sparing approaches. There's partial nephrectomy and ablation. These typically treat just the mass, spare the kidney. They are done usually in a minimally invasive fashion, so you maximize kidney function, minimize the risk of complications. And obviously, anytime you cut into a kidney, there's risks related to that: bleeding, urine leaking, losing the entire kidney, and there's always a risk of this tumor coming back. Those risks are in general pretty low. And lastly, we have radical nephrectomy, or removal of the entire kidney. We try not to do this for the small renal mass, but occasionally you have to. This is typically reserved for larger tumors, patients with more advanced cancers, where we're really trying to definitively treat that, and obviously we can influence kidney function. Interestingly, if you look in the small renal mass world, and a lot of this data was done by Sarasuka, who's a good friend who's going to talk behind me, what you see here is that no matter how we treat a patient with a small renal mass, or this is even a T1 renal mass, whether you take out the entire kidney, you do a partial nephrectomy, you ablate it, or you watch them, the chance of them, first of all, being alive at 10 years, that's your bright yellow here, and then dying of something other than kidney cancer is much, much, much higher than the chance of someone dying of kidney cancer, no matter how they were treated. So I'll kind of sum this first part up here, just to put it all in context. We know that the increasing incidence of kidney cancer in the US and around the world has been driven by these small renal masses, and they are incredibly common, particularly in the US. We know that there's heterogeneity here. You can have truly benign tumors. You can have cancers that are benign behaving or indolent. Very rarely can you have aggressive cancers in this space. And no matter how we treat patients, they're going to do really well. And these are important messages to spread amongst the community and tell people when they come in really scared about these small renal masses. So I'd like to spend the remaining of the time talking about active surveillance. And I'm going to do it in a brief kind of history lesson here. We'll give you a little background on these programs and why we do them. So first, let's start with principles of active surveillance. And this is not just for kidney cancer. This is for any disease. First of all, it's really got to be a disease where overtreatment exists. And I hope I made that point to you, right? We're taking out a lot of tumors, we're subjecting people to surgery who may never need it. Second factor, surveillance has to be possible and in general should be easy. We've got CT scans, we've got MRIs, we've got ultrasounds, we've got great ways to look at these masses. And the last and most important point, that if something changes, we can intervene before there's a bad outcome, before this cancer becomes truly aggressive or dangerous. And I will tell you, we meet all of these three things. This is just kind of summary data. And if you look at all of the both retrospective, meaning looking backwards, and prospective data, meaning looking forwards, we now know that active surveillance is truly a safe strategy with at least 10 years of data. And the term we like to use is non-inferior, meaning it's not worse than surgery, it's not worse than ablation. We know we can meet the same high bar of excellent cancer outcomes in those patients. We've also learned, and we'll show you some of this data, that growth rates in general for these masses are slow and similar for most people. Incredibly low rates of metastatic progression. At most, 2% of patients will develop metastatic disease in 10 years. It's probably lower than that. We know that if you delay intervention in a surveillance program, it's safe. We don't lose any cancer risks. We aren't compromising cancer outcomes. And in general, we don't lose the ability to do either a partial nephrectomy or thermal ablation. So because of that, the AUA, this is the American Urological Association, has finally started to embrace active surveillance as an initial management strategy for patients with small renal masses. They acknowledge it's truly safe for patients under 2 centimeters and for certain patients up to 4 centimeters when the risk of intervention or the death from other causes outweighs the risk of kidney cancer and kidney tumors. Other guidelines around the world have been a little slower to adopt, but they are coming along. The NCCN says selected patients can undergo surveillance. ASCO says in patients who are sick or older. The EAU is the most conservative, really saying in frail or comorbid patients. And I think their statement's a little dated, to be honest with you. But this is what's going on around the world, and we recognize these things are slow to pick up and slow to adopt. And so when we think about managing cancer, these are the things we think about in general, right? What is the tumor? What is the patient's health factors? And how can we compare our treatment strategies? And for kidney cancer, it's no different. So if we start at the bottom of this kind of pyramid, the tumor factors, well, we know these small renal masses in general aren't going to be aggressive. We can really heavily weigh on patient health factors. How suitable are you for surgery? What's your life expectancy? We know that in general, our management strategies are going to be equivalent. So a lot of this comes down to patient preferences and values, as well as our preferences and values as surgeons and managers of this disease state. And I hope to walk you through that in the last bits of this talk here. So this is our program. The Disarm Registry, or Delayed Intervention or Surveillance for Small Renal Masses, has actually been open since 2009. We're 15 years old. The last time we pulled the data, the paper will be published soon, 993 patients. We have well over 1,000 patients in the program now. The median follow-up is about 5 years, meaning the average patient's been followed for about 5 years, but that number never gets really long because we keep adding patients in. So it keeps our follow-up relatively short, but we have a significant number of patients who've been followed for 7 to 10 years. This now involves the University of Pennsylvania, where I'm at. It started at Hopkins, includes patients there, Beth Israel Deaconess in Boston, as well as Columbia in New York City. And what we do and what we've learned, our surveillance strategy has changed, but in general, we watch patients every 6 months for the first 2 years. If things are stable after 2 years, we typically move patients to annual imaging. We love to use ultrasound. Once you know where a mass is in the kidney and that it's there, ultrasound is a great, cheap, inexpensive, no radiation way to look at a renal mass. Most patients, we alternate CT scans or MRIs with that ultrasound so that we can keep an eye on their entire abdomen. We very rarely look at people's chests because, as I explained before, and I'll show you more data later, the chance of these tumors spreading around the body and worrying about their lungs is incredibly rare. In the first 400 or 500 patients that we included in this registry, we imaged their chest all of the time, and we found nothing. So we stopped subjecting people to unnecessary chest imaging. But what we tell all patients is, even though we've got 10 years of data and 1,000 patients behind us, these surveillance programs are going to be highly individualized. Some patients we may image at 3 months. Some patients we might go directly to annual imaging. based on what their tumor looks like or some of their other factors. And so these things can be highly individualized and should be highly individualized. We don't just say, this is the way we've always done it, so this is the way you're going to do it. The reason we extend the follow-up after 2 years is based on what we've seen with long-term data about growth rates stabilizing over time. So we know we see a lot of fluctuation in the first year or two. And we thought, well, initially, maybe these tumors are, some of them are really growing fast and we're missing something here. Or maybe it's because we're worried about, we're rushing them off to the operating room. So we're just selecting out the slow growing tumors. Long story short, that's not true. What we actually found is that this is all related to mathematical artifact. And I think this is a fun exercise. Let's just think of a small renal mass as a perfect sphere. Let's call this one 3 centimeters in size. It's actually, if you take the same radiologist or the same radiographer on the same day and you measure that mass, but this time you happen to measure it a little bit off the midline, or you happen to catch it at an angle, you may be off by a millimeter or two. And when you're dealing with a small renal mass, a millimeter or two, if you're changing your change in size over only 4 months, 5 months, 6 months, or even a year, you may dramatically overestimate changes in size into changes in growth rate. And that's why we see that stabilization over time. Most of these masses are not growing quickly at all. And so it makes us think, all right, now we're watching a patient with a small renal mass. Most of these things are going to grow slowly, on average about a millimeter per year. When are we going to the operating room? And these are the things we think about, and I'll walk you through all of them. I'll tell you right off the bat, tumor size is the most important and reliable predictor of what we call metastatic potential, the ability of this cancer or tumor to spread. So I've showed you this data already. I'm not going to show you that one again. I've showed you the genetics data. We understand that these tumors are genetically boring. Here's some really good data. This study was from Memorial Sloan Kettering. And what this shows is the rates of metastatic disease for tumors under 4 centimeters. Basically, it's 0% for masses that are less than 2 centimeters. It's about 1% for masses that are less than 3 centimeters, and that's based on data from all over the world. Maybe as high as 2% for tumors in the 4 centimeter range. 2% could be a huge number for a really young, healthy person, but it may be a very low number. And so that's why we talk about putting these things in the context of a patient and their preferences and everything else they think about. So I told you I'd give you a little history. This is the first active surveillance data we saw. This was a study that mapped out retrospectively tumors that were watched and patients that developed metastatic disease. And these studies scared people because you saw tumors that grew quickly, all of those curves that have kind of a slope to them, had patients who had metastatic disease. But if you really delve into this data, that's actually 7 patients over the course of about 10 years and hundreds of patients. And each one of those patients had a number of things in common. Their tumors actually started at about 3 centimeters. They doubled in size. So metastatic disease actually developed when those tumors were 6, 7, 8 centimeters in size. They were no longer small renal masses. And most of those patients had a period of either non-compliance or non-following up. So they weren't able to keep their appointments, or they didn't keep their appointments for a variety of reasons. And so it created a lot of strength for us, helping to understand, who do we have to worry about? Well, we have to worry about patients with bigger small renal masses, 3 to 4 centimeters. We got to make sure they're not doubling in size, and we got to make sure people keep their appointments. And so it created the foundation. And so here's kind of those data in that statement. And that provided the foundation for moving forward. Since then, there's been a number of really good prospective studies, and I'll highlight just some of them. These are from my good friends Mike Jewett and Tony Finelli in Toronto. This is the Canadian Consortium of Small Renal Masses. And interestingly, they do what we call a histology-based surveillance program. They biopsy every single patient who walks in the door with a small renal mass. They know if they've got clear cell, a papillary kidney cancer, chromophobe even, and then they can map out their expected growth rates. Now, these are estimated growth rates, and you can see clear cell is estimated to grow faster than other tumors. So this helps set expectations for patients about where their tumors are going to be. Interestingly, they've only had 2 patients develop metastatic disease in their history. Here's our data. 1 patient in our program developed metastatic disease. And in retrospect, that patient developed metastatic disease and died within 6 months of their diagnosis. We missed a metastatic lesion at initiation. but that's what our data showed. We enrolled that patient in a surveillance program. So they actually weren't truly a localized small renal mass. They had metastatic disease when they showed up at the door. So as I said, tumor size is the most reliable predictor of metastatic potential, and therefore it's the best trigger for intervention. And this is what we think about size and these tumors. When they're less than 2 centimeters, zero metastatic risk, about 15% of patients are going to progress to treatment. So we know active surveillance is safe for just about any patient in this profile. As you get bigger, 3 to 4 centimeter range, the metastatic risks 1% or less. About 30% of patients are going to go to the operating room because they get nervous or we get nervous. And so we definitely survey these patients, continue to keep them at 6 to 12 month intervals. We know they're more likely to grow, and so we keep a close eye on them. And obviously, once they get above 4 centimeters, the metastatic risk starts becoming very real. Most of those patients should go to the operating room unless they have a reason not to. And I know this is a kidney cancer meeting, but a lot of people are familiar with prostate cancer. And so this is familiar to our prostate cancer surveillance analogies, where we talk about very low risk disease, low risk cancers, and favorable intermediate risk cancers. And I think this is a nice analogy where we understand none of those patients are going to die of prostate cancer. Similarly, none of these patients should die of kidney cancer. We can certainly keep an eye on them in a very regimented, safe way. So what about growth rate? Well, growth rate certainly informs our active surveillance, but I'm going to tell you it's not in the way you think. And what do I mean by that? Well, we think the faster something grows, the more aggressive it should be. It's not exactly true, and I'm going to show you data. What we do know is that if a tumor is not growing, zero risk of metastatic kidney cancer. We've seen this around the world many, many times. I'll show you the data. We know clear cell is more likely to grow quickly, but not always. And an elevated growth rate predicts intervention, going to the operating room, but not always a cancer outcome. So I can't take full credit for this first statement. This comes from my good friend Marc Olivier, who's in Paris, hopefully watching some of the games. Zero growth equals zero risk of metastatic kidney cancer. Now, I just told you about a patient with a small renal mass who had metastatic disease. That is true. There are about 2% of patients, 2 to 4% of patients with metastatic kidney cancer will show up with metastatic disease, cancer in their lungs, cancer in their bones, and a small renal mass. But it is incredibly rare for a small renal mass that does not have metastatic disease to progress. It's basically never seen. And when we look at the growth rate data, these are studies from all over the world. In all 8 of these programs, there has never been development of metastatic disease in a tumor that was not growing. So if your mass is stable in size, if it is not growing, you are not going to develop metastatic disease. What did I mean by clear cells more likely to grow quickly, but not always? Well, I showed you the Canadian data before. This is their data mapped out by histology, kind of kidney cancer. The clear cell kidney cancers are the orange ones. They're much more common. And you see, if you do the math, they're more likely to grow quickly, but you see a lot of clear cell tumors that grow slowly. And you'll see some papillaries and chromophobes that will actually grow quickly. So it's not a perfect science. Yes, mathematically, clear cells are predicted to grow faster than others, but not always. Eric Kaufman at Roswell Park did a beautiful study a few years ago. He took 100 consecutive patients and he put them all on active surveillance, no matter their age, no matter what their comorbidities were, if they had a small renal mass. And he did biopsies once again. And you see a very similar curve here, right? You see this big, this is called a waterfall plot. And you see this big, beautiful curve, and you see about 15 to 20% of tumors that grow quickly. Most of them are clear cell, but not all of them. So what can we learn from this? Well, we know no matter what the histology is, about 15 to 20% of these are going to grow quickly. And what we mean by quickly is 5 millimeters per year or more. 60% or 70% are going to grow very slowly or not at all. And actually 15% of these things actually might shrink and go away. So interestingly, in Eric's program, the most important predictor of intervention was tumor size. And he did this prospectively. It wasn't the growth rates. It wasn't the histology. It was actually the size of the tumor that helped predict who was going to end up in the operating room. And that leads us to an elevated growth rate predicts intervention, but not necessarily cancer outcomes. I'm going to show you 2 more beautiful water plots, and guess what? They all look the same. This is Fox Chase, our good friends across town in Philadelphia, Bob Uzo, Mark Schmaldone, Alex Kudikov, 500 patients, 15 years of follow-up. Yeah, once again, 15 to 20% of these are going to grow quickly. And blue and orange here aren't the type of cancer because they didn't biopsy their patients. The blue ones are the ones who went to the operating room. And you see, the more quickly a tumor grows, the more likely you were to go to the operating room. And if you map it out, Actually, about 40% of their patients who had quickly growing tumors went to the operating room in 5 years. But guess what their oncologic outcomes were? The same as everybody else. There wasn't what we call upstaging. There wasn't more aggressive cancers. There was no more recurrences of kidney cancer there was in any other patients. So growth rates make us nervous. They make patients nervous. They make surgeons nervous. They make cancer doctors nervous. So we go to the operating room, but we're not seeing any adverse outcomes from a cancer standpoint. And this is our data from Disarm, same exact thing. 15% of patients, their tumors will go quickly. They're going to the operating room, but we're not seeing any adverse events. This is our what we call delayed intervention data. Yes, the patients who went to the operating room had slightly faster growing tumors, but their pathologic stage, their oncologic outcomes, risk of cancer coming back, or their ability to do a partial nephrectomy was unchanged. We have learned a bunch about tumor size, though. We know once a mass is over 3 centimeters, those tumors actually will grow quicker than tumors that are under 2 centimeters. And we know they're more likely to undergo intervention because of that. So I'm going to clarify those statements I said before. Zero growth, zero risk of metastatic disease. Clear cell, more likely to grow, but not all of them. An elevated growth rate predicts intervention. But the big caveat here is all of these studies, all of these patients are going to the operating room when their mass is under 4 centimeters. I would say I firmly don't know how growth rate impacts oncologic outcome or metastatic risk once we cross that 4 centimeter threshold. My 1,000% honest opinion is that it does matter. It matters when you're dealing with a 5 centimeter, 6 centimeter, 7 centimeter tumor, but it doesn't matter as long as you intervene before something gets above 4 centimeters. So what do we think about growth in our program? 0 to 5 millimeters. We're watching those patients basically every 6 to 12 months. If they're over 3 centimeters, we tend to keep them at 6-month intervals. If they're growing more quickly in the 15 to 20% of patients with 5 millimeters per year, we will consider shorter interval imaging or a biopsy if they're a really small mass. If they're bigger masses, we tend to move more towards the operating room because we know kind of the writings on the wall. They're going to hit 4 centimeters, and we don't want anybody to die of kidney cancer. The last thing I think it's worth, last couple of things I think worth touching on are biopsy. So what does biopsy help us with in the active surveillance literature? And I showed you the Toronto experience and the Roswell Park experience where they biopsied everybody. And I showed you Fox Chase and our data where we biopsied almost nobody. About 15 to 20% of our patients get biopsies. What does biopsy help us? Well, from Toronto and from Eric's data, we know it'll help us predict growth rate. But we also know from our data that it's not a requisite for safe active surveillance. You can do safe active surveillance without it. But we do know renal mass biopsy now very clearly can help us avoid the overtreatment of benign tumors. The Music group, which is out of Michigan, has shown us that if you do more biopsies, you're going to put more patients on surveillance and you're going to avoid surgery. You'll decrease rates of surgery for benign tumors. This was data from a collaborative of Irvine, Northwell, and Hopkins. And you can avoid radical nephrectomies or removing an entire kidney for a benign tumor if you do a biopsy. So that's one of the big indications for biopsy. Now, if you've got a small renal mass and you think the entire kidney needs to come out, do a biopsy, whether you're a patient or other provider. Make sure you're not going to remove a kidney that's got a benign tumor in it. And you can actually reduce costs and the morbidities related to that by avoiding unnecessary surgery. So renal mass biopsy informs our predicted growth rates and helps us avoid unnecessary treatment by identifying benign tumors. Last couple of points. We're not going to see stage progression. These tumors don't get worse under 4 centimeters. Eric's group, once again, he defined this. He said, we want to look for patients who have developed symptoms, hematuria, flank pain, anything related to a kidney tumor. And 3 of their patients did, according to their prospective study, but those were all unfavorable histologies, meaning they had high-grade tumors when their kidney came out. In any of the other registries, no patient has ever developed symptoms. So patients ask all the time, hey, I'm on surveillance. Is there anything I should be looking for or anything, I can do? You can keep your appointments. I tell them all, you should not worry about this. This is our job as the urologist, as the provider watching this. You keep your appointments. It's our job to measure and keep an eye on your tumor. And then really important here, patient preference and illness uncertainty are a big deal here. It's really weird to think I might have a cancer in my body and I'm not going to treat it. We recognize that. So that's why I spent half an hour today trying to explain to you why these things aren't dangerous, and hopefully you can share some of that message. What does the data tell us? Well, the data tells us that illness uncertainty is a real phenomenon. There's some data out of MD Anderson, which says that mental health and illness uncertainty are problematic for patients in surveillance, but when they're in a program, it actually doesn't decrease. It doesn't get worse. Rob Hamilton and the Toronto group in a different study showed that biopsy might actually help, in some patients, makes them more psychologically distressed because now they know they have a cancer. Where in some patients, it's very reassuring. So you see this dichotomous outcome. And so you have to talk to your patients about what a biopsy and what that outcome may mean for them. What our data has shown that patients who are in an active surveillance program actually have worse quality of life than patients undergoing surgery, but that's driven entirely by their physical health or their perception of their physical health. Because in general, patients undergoing surveillance are slightly older, slightly worse health context. But importantly, mental or emotional quality of life actually improves for all patients with a small renal mass, whether they have surgery or whether they're in surveillance, as long as they're in a structured program. And this weighs in importantly because we know even in our program where we follow patients and they're doing well from a mental health standpoint, about 40% of patients in the first 5 years are just going to say, you know what? I'm tired of watching this. I don't want to do it anymore. I just want it out. And guess what? That's okay. So the last point I'll make is that we are totally underutilizing surveillance. It's hard to quantify these things in kind of large national databases. So we use something called non-operative management, and we see at most 10 to 30% of eligible patients are undergoing non-operative management. It shouldn't be 100% of patients. We can do better. And what can you guys do as patients, as advocates, and the physicians in the room? Well, you can understand why. So these are data from what's called SEER Medicare, big national cancer database. And a good resident now at Hopkins did this data when he was doing research with me. 13,000 patients saw 3,000 urologists for a small renal mass. And we mapped out what was their management strategy. And you saw these huge fluctuations and variations in who offered non-surgical management. And in fact, 60% of those urologists only offered treatment, never even thought about offering a patient active surveillance or non-surgical management. And we know our guidelines say we should think of things like age and life expectancy and tumor size when we're picking what you see on this figure, non-surgical management, ablation, partial nephrectomy, or radical nephrectomy. But guess what the most important thing was? It was the individual urologist they met first. It wasn't how big their tumor was or how old they were, the things we should be using to make decisions. It was what that urologist believed. And we know this holds true for other cancers as well. There's correlations between prostate cancer surveillance and small renal mass surveillance. There's correlations between thyroid surveillance and small renal masses at institutional levels. So these are really important things to think about. And why is that? This disease is relatively rare. People are relatively scared. And this is great data, once again, out of Canada. Patrick Richard ran this qualitative study. They asked patients, what was the most important thing when you were told you had a small renal mass? And they said it was their physician's recommendation, how the doctor recommended, what the doctor explained. I trusted them. There was no better person. And so it really is important for us as physicians and as patients and as patient advocates to say, don't just trust necessarily the first person you see. Seek out the experts here. Seek out the people who are really comfortable managing small renal masses. So in summary, active surveillance is safe and durable. The first urologist patient encounter is the most important, so take ownership and onus over this. Tumor size is our most reliable predictor of metastatic disease, and therefore it's our best trigger for intervention. We can learn a lot from tumor growth. If it's not growing, you're safe. If it's growing faster, you're going to be fine as long as you intervene before 4 centimeters. Biopsies can help us avoid surgery for benign tumors, and illness uncertainty and patient preferences really help us pick good choices for our patients. So here's my contact information. If anybody has any questions, concerns, I'm always happy to talk to you. I love talking about this disease. I love talking to patients with small renal masses or any form of kidney cancer. So once again, Scott, John, Bryan, and the KCA, thanks again. I'll take down my slides.
Thank you so much, Phil, for that tour de force of not only localized kidney cancer, but active surveillance in kidney cancer. Do you have maybe, I know you have to go be on call. Do you have 5 minutes for just a couple questions?
For you guys, I got more than 5 minutes. You tell me what you need.
All right. Well, a couple questions. One is just how often should these imaging studies be done? You hinted on this, but patients definitely worry about excessive exposure in certain scans. And you mentioned using ultrasound rather than other cross-sectional imaging, but can you speak to frequency of imaging?
Yeah, we like starting everybody off at 6-month intervals. So I tell everybody the first time I meet you, I want to see every 6 months for the next 2 years. And obviously we can change that if somebody's nervous, or let's say they got a family vacation. There's nothing wrong with 5 months or 7 months or 8 months, whatever it may be. But in general, I want to make sure that they have good cross-sectional imaging, a CT scan or an MRI within those first 2 images. So if you showed up and you don't have a CT scan, you're getting a CT scan either immediately or within the first 6 months. And then we talk about it. I like to, if you've had good axial imaging, I like to use ultrasound for the next one based on what that ultrasound shows. We'll ask a patient, hey, do you have a preference, MRI, CT scan? Some people have no problems with MRIs. Some people hate the smaller tube. And so, we'll make those decisions. We do try to avoid radiation, especially in younger patients and prolonged exposures. So MRIs become one of our mainstays for surveillance with ultrasound, but a good old CT scan is a great, easy, very reliable way to look at these things too. And modern CT scanners have a much lower radiation than they used to.
Phil, do you mind actually just sharing that last slide one more time with your contact information?
Yep.
One question is, can nephrectomy for tumors less than 4 centimeters ever increase the risk of subsequent metastatic disease? So can the surgery actually, increase your risk of spread?
Yeah, that's a really good question. It's a loaded question, John. So I would put it this way. We've done lots and lots and lots of data, and the best way I can put this is that the surgery does not impact the risk of metastatic potential. But what that surgery tells you is if you're doing a radical nephrectomy for a 4-centimeter tumor, there's something about that tumor that made it challenging for a partial nephrectomy. It might have been in the center of the kidney. It might have been more central. It might have had kind of an amorphous border instead of what we surgeons like to call a well-encapsulated tumor. Those things likely increase the risk of metastatic progression. We don't have good answers for, why or what those defined outcomes are, but it's not that the surgery is increasing the likelihood of cancer coming back. It's that tumor that made you get a radical nephrectomy, it was more likely to recur.
And then I know you went through the staging of kidney cancer, but one of our participants recently had surgery for a stage 1B kidney cancer. Do you mind just reviewing what that means?
Yeah, so I kind of went over that relatively quickly, but stage 1 we call small and confined to the kidney. There's stage 1A, those are the small renal masses. Those are the ones that are 4 centimeters or less. Stage 1B is still a small kidney tumor, but it's between 4 and 7 centimeters. They still have excellent outcomes overall. There's a little bit of uncertainty about active surveillance in that population, and I think that's the big question mark there. We know surveillance is super safe in the T1As. Most patients with T1Bs in this country are still getting, and around the world, are still getting treated.
Okay, last question, and then we know you have to go to treat a stone. Is it safe to do a biopsy? Does biopsy ever cause spread? Would it be better to avoid a biopsy if you can?
Yeah, biopsies are incredibly safe. And I would now say there's robust data to support biopsy as a very safe strategy for increased diagnostics. What I tell all my patients now, the risk of a biopsy, there's a risk of bleeding. About 5% of patients who get a biopsy will have bleeding around their kidney. 1% or less will require transfusion. It's not very high risk. There is basically no risk of tumor seeding. There were reports of tumor seeding 20, 30 years ago when we had different biopsy techniques. We used a totally different biopsy needle and gun. Now with modern techniques in what's called a coaxial sheath, the way a biopsy is taken is the needle is inserted into the tumor and then pulls back into a sheath so that it's actually never exposed to your inside. So there's no risk of cancer spreading with a biopsy if done with modern techniques. I tell people the biggest risk of a biopsy is that it's not going to help us make a decision. And we know 10 to 15% of the time, even in really good hands, really experienced centers, you're going to get a non-diagnostic biopsy, meaning the tissue that comes out, the pathologist can't really tell you what it is. And we know biopsy is good at picking out cancers and from benign tumors, but it's not good at picking out aggressive cancers. And we know that actually by volume, the vast majority of aggressive cancers are low grade. So it's like trying to find the needle in the haystack. Yes, if you get a high-grade tumor or a high-grade biopsy, you know you have an aggressive cancer. But if you get a low-grade biopsy, it doesn't necessarily help you out. And I think it muddies the waters. So I tell all of my patients, assume you have a kidney cancer. It'd be great if you don't, but assume you have a kidney cancer. Is biopsy going to help you make a decision here? And if it will, it's safe. We do them all the time. About 20% of our patients. So it's not all the time, 1 in 5, but we do a lot more than we used to.
Thank you so much, Phil. I really appreciate your time. Thank you for sharing your expertise with us, and good luck with the rest of your fall.
Thanks all. Have a great weekend. What a great meeting.
John, you're muted.
Sorry about that. That's a really great transition to our next speaker. You know, Dr. Pierorazio spent a lot of time talking about lower risk localized kidney cancers. But unfortunately, you know, many people are diagnosed with higher risk, but still localized kidney cancers. And as we talked about when we were talking about our KCMC, there can be a role for what's called adjuvant therapy of kidney cancer. So I'm delighted to introduce my co-chair. We like to swap intros. Dr. Tykodi is an associate professor both at the Fred Hutch Cancer Center and the University of Washington, the medical director of our kidney cancer program and our kidney cancer multi-specialty clinic, and heavily engaged in our immunology research efforts at the basic science level in terms of trying to make care better for kidney cancer patients. So I'm delighted to introduce Dr. Tykodi to talk about adjuvant therapy for kidney cancer.
Great, thank you, John. I'm delighted to have a chance to talk this year on a topic. Are you seeing my slides in slide view? Hopefully,
Yes.
it looks good to me. Good. You know, adjuvant therapy is somewhat new to us in the medical oncology side of care for kidney cancer. So it seems like a very relevant topic this year to cover in a few minutes. So adjuvant systemic therapy for high-risk renal cell carcinoma. How do I advance? These are my disclosures. So I wanted to make sure we're all on the same page. When we talk about adjuvant cancer treatment, what does that word mean that we're using? So adjuvant therapy is a cancer treatment that's given after a primary or a definitive treatment, usually surgical therapy and removal of the visible tumor. The goal of this adjuvant, this add-on therapy, is to decrease the chance of the cancer coming back. And we know when we know the natural history of patients by their diagnosis, that even in patients where all of the visible cancer that we see on scans has been taken out surgically, many patients are ultimately going to have a recurrence, which means that there's still some residual cancer in their body that we can't see by our conventional test, by body scans. And so that's typically what's referred to as a micrometastatic disease burden, or minimal residual disease is something else that gets used a lot. So what are the adjuvant treatments that could be applied? Pretty much just about anything you can think of that is used for cancer therapy. Older generation chemotherapy drugs that are toxic to tumor, hormone therapies, radiation treatments, targeted therapies, and immune therapies for different diseases all potentially have a role as an adjuvant therapy. So if we think about kidney cancer specifically, and we think about what happens after removal of a tumor, this shows you schematically the range of diagnoses of tumor by stage. Localized tumors restricted to the kidney, stage 1, 2, or 3, or metastatic stage 4 disease. And if we think about the risk, and we talked about this a little bit earlier in Dr. Braun's talk, a stage 1 tumor, and so the topic we just had, but in all comers, if you look at a series of tumors that fall into this category, the lifetime risk of recurrence is typically in the 5 to 10% range. Stage 2 tumors, more like 20 to 30%. Stage 3, 50 to 60%. And metastatic disease, so a tumor in the kidney and somewhere else in the body, but a discrete site of disease spread that can be attacked surgically. You can practically remove all of the visible cancer. So by the criteria of a scan, the patient appears to be cancer-free. We know those patients, if you follow them for several years, have at least an 80+% chance of the cancer coming back. So what can we do? What are the options? What's been looked at in the field of kidney cancer? There is a literature about trying to use radiation therapy. So after a nephrectomy, what if you did radiation to the surgical bed? Maybe you're going to kill off any residual disease that was left behind. And there's a smattering of small trials, randomized trials, or single arm studies that have been analyzed as a group. The total patient number is fairly respectable, over 700 patients. And there was no clinical benefit and no survival benefit that was ever seen with radiation therapy. So we don't do this. We don't offer it to patients, not thought to be a helpful intervention. We saw earlier in Dr. Braun's talk kind of the sequence of medical therapies in the field for kidney cancer. And if we go way back, the first systemic agents that were widely used for patients, the cytokine drugs, interferon alpha and interleukin-2, that were being used in the metastatic setting, well, they were looked at in trials to see if there was a role for these drugs applied in the adjuvant setting. So post-surgery, post-nephrectomy, the patient that was cancer-free at that point in time. And so these trials, shown here, 3 larger trials, and the hazard ratio on the right-hand side, a number less than 1 would imply that the intervention, the cytokine treatment, is improving the outcomes for patients. 1.0 would mean no difference versus no therapy. And higher than 1, unfortunately, means that it's tending towards the intervention is somehow actually harmful. So all of these results showed no benefit of applying interferon or interferon plus IL-2 in combination in the adjuvant setting. And so those therapy options were abandoned. Interleukin-2 is a cumbersome drug. It's not easy to administer. You have to put patients in the hospital. There was a time when it was the preferred frontline drug for patients, and there was an effort to see if using it early after nephrectomy in the absence of cancer might actually be the smart way to use this drug and apply it in an adjuvant setting. Not a very large trial, but no trend of improved outcomes. And so that was also abandoned as a sensible option for patients. This trial summarizes really a massive amount of work in the field. So as the therapy for kidney cancer evolved, and it went from the cytokine drugs to a collection of so-called targeted drugs, oral medications that we used as the best therapy for these patients for about a decade of time. Once they were shown to have efficacy in the metastatic setting, once again, the question was asked, well, what if we use them earlier in the course of therapy? What if we try them in the adjuvant setting? Will their success be better? And should that be their role? And so you can see here 6 large randomized, placebo-controlled. These are all international trials. You can see the patient enrollment, extremely large trials with over 1,000 patients. And if you sum up these trials, over 8,000 patients participated in these studies. And the take-home message on the right-hand column here, unfortunately, the red text means lack of benefit. And so 5 of the 6 trials showed no improvement in outcomes with the use of 1 year, and in some cases even 3 years of the oral medications. And you can see many of you, I'm sure, are familiar with the names of these drugs, which still are sometimes used in current therapy. But sunitinib, sorafenib, pazopanib, axitinib, and everolimus. You can see one of the studies does have green text here. The S-TRACK trial did have a positive outcome by the primary endpoint being disease-free survival. So you're following patients from the time that they start therapy when everyone is cancer-free to participate in the study. And over time, if your cancer comes back, you then have an event where you're no longer part of the disease-free group. But just because the cancer comes back, you're not instantly dead. You're now going to have to manage metastatic cancer and receive therapy, and hopefully that's successful for a reasonably long time. So disease-free survival you encounter first if you're following these patients on behalf of the trial, and that was positive, suggesting the tempo of disease appearance was delayed with sunitinib. But the goal of these trials is to show that ultimately you have better overall survival, that you're stopping cancer from coming back and you're saving lives. People can't die of their cancer if they don't have it. And that was never seen in this trial. Unfortunately, the overall survival endpoint was identical between the treated patients and the placebo control, with the fear being that perhaps you're slowing the cancer down, but it's going to come back ultimately, and you're not really changing the overall hazard for the patient. And perhaps what comes back is actually harder to treat. And at the end of the day, you're really not getting yourself ahead, like the disease-free survival endpoint suggested. There was also a second trial with sunitinib. You can see the ASSURE trial and the S-TRACK trial both used the same drug. The ASSURE trial had no trend of benefit for sunitinib. And so it was a confusing picture discordant trials, no survival signal for sunitinib. And it was widely discounted despite an FDA approval in 2017. Most practitioners did not feel it was likely to be efficacious, and it was not commonly offered to patients despite the FDA approval. The newest drugs that we have, and again, in the first hour, we heard about them quite a bit. The immune checkpoint inhibitors, we're now using them all the time. We perceive them to be the most efficacious drug class for metastatic disease. And so once again, we're at a point of saying, well, if they work for advanced disease, should we be using these in the adjuvant, the preventative setting? And so we're going to spend the time this morning taking a look at some of this data. And so the first trial I wanted to show you, sorry, I got to move this out of my way. What was called Keynote 564. The schematic for the trial was shown here. This is a study with the drug pembrolizumab, or the commercial name is Keytruda. It enrolled patients post their nephrectomy surgery, so they're cancer-free by imaging criteria. The study identified these 3 different categories of patients: intermediate high risk that were stage 2, and some stage 3 patients, a high-risk group that were a different subset of stage 3, or a T4, a more advanced primary tumor, and then a subset of patients that were truly metastatic but had had all of their disease removed surgically. You had to start therapy within 3 months of your last surgery, mostly nephrectomy, but if you had a metastatic lesion removed, whichever surgery came last. Of course, no prior therapy was allowed. Patients were randomized to receive either pembrolizumab in a conventional way, 200 milligrams every 3 weeks for 17 doses, a year of therapy, or a placebo. Patients got a sham infusion of saline. So we behaved as if we were giving treatment to all the patients that were in the trial. The primary outcome was presented at ASCO 2021. And the discussant for that presentation, I thought, had a nice figure, and I've copied it here, that tried to give you the feel of the relative risk of the patients that were involved in this trial. So even though its intent is to try and enroll a fairly homogeneous group of patients, it only allowed clear cell histology. And it tried to pick out patients at the highest risk of disease. But you can see it allowed some stage 2 patients that had high-grade tumors. Their risk of disease recurrence, if you go to the literature, is only about 20% at 5 years. Stage 3 patients, patients with T4 tumors, higher risk still, nodal involvement by disease imparts relatively higher risk of recurrence, all the way to the stage 4 NED patients that only have about a 20% likelihood of staying disease-free up to a 3-year endpoint. So the relative risk of the patients involved was really quite heterogeneous in the study. But shown here is an outcome figure, so showing the disease-free survival. So over time, the proportion of patients that maintain a disease-free status. And so 100% at the outset, and every time a patient has recurrence, this line falls down. And you're comparing patients that got the pembrolizumab drug, the green line, to no therapy, the brown line. And you can see the pembrolizumab cohort always does better than the brown line, but the relative difference increases with the perceived increased risk to the patient. So the higher the chance of the cancer coming back, the better the effect of the therapy that was applied, to the point that the most dramatic difference is in the stage 4 patients. Although the total number of patients enrolled in these higher risk categories is fairly small. So most of the patients look like this, stage 3 patients. But all of these categories had a significant benefit of the pembrolizumab drug. There was no group that the drug did not appear to have benefit to the patients treated. There was a 5-year follow-up that was just presented earlier this year. Now, this is the entire cohort of patients, again, showing the disease-free survival outcome, showing that the benefit is sustained over time to at least 5 years of follow-up. And the little lines here show you 1, 2, 3, and 4-year landmarks. So you can see at 4 years that the treated group is doing better than the non-treated group, but it's imperfect. There's still patients that, despite the therapy, have the disease recur. And so at 4 years, 35% of patients have had a disease recurrence despite the use of pembrolizumab. The final figure here was the new data for 2024. And so it had never been the case that an adjuvant therapy for kidney cancer showed us improvement in this disease-free survival, the decreasing the frequency of cancer recurrence, but then translating into better overall survival until now, until the Keynote 564 data. So the survival trend is shown favorable for the treated group versus placebo, and this achieved a statistically significant difference based on the model of the trial. the study's still ongoing. We're still going to follow these patients further. But for the very first time, we have a drug that we now believe not only decreases the risk of recurrence, but translates to true overall survival improvement for the patients that receive an adjuvant therapy. So this was widely heralded as a huge advance, a big step forward in the field, the first time we have a drug that has these properties. Because of the success of pembrolizumab, it did receive FDA approval in 2021. So we've had it now for a couple of years and are actively using it in our clinic and for our patients that have a disease that looks like the enrollment for the Keynote 564 study. But this slide reminds us that nothing is easy in the oncology world. Cancer is a tough foe. And so what's shown here in 4 panels is that there were other studies done very much like Keynote 564 with similar drugs in a similar fashion. So wouldn't we expect that they would all share a similar degree of success, and we would ultimately have a menu of options for adjuvant therapy? And the answer is actually no. That's not how it worked out. And so the top left panel here is once again the Keynote 564 data we were just looking at, showing sustained benefit of pembrolizumab versus no therapy. On the right-hand side is a very similar trial done in a similar way, 1 year of adjuvant therapy with a drug called atezolizumab. That shows no separation between the treated and untreated patients and no benefit of this drug when applied in a similar fashion. The bottom left, the PROSPER trial, used the drug nivolumab, again in a similar way. The approach here delivered a dose of nivolumab actually before the surgery was completed, followed by the nephrectomy surgery, and then more nivolumab after the surgery. So moving up the exposure to the drug into what's called the neoadjuvant setting, that it actually precedes the surgical therapy. But this trial, again, was a negative trial with no trend of benefit for the nivolumab. And then on the bottom right panel, a 2-drug cocktail, nivolumab plus ipilimumab, which we're familiar with as one of our options for metastatic disease, now applied in the adjuvant setting. And once again, no trend of benefit with the combination. So what's going on here? How can we interpret 4 trials where 3 were failures, yet 1 was a success? And the answer is we don't really understand for sure. It's caused a lot of discussion in the field about what's going on and where do we stand in the adjuvant setting. Some of the explanations offered is that the atezolizumab is slightly different than the pembrolizumab. It blocks a protein called PDL1 rather than PD1. And that class of drugs has not fared as well in kidney cancer trials, so perhaps it's slightly less efficacious. This PROSPER trial, because it tried to deliver therapy before the nephrectomy, it's limited in applying pathologic staging, and so the enrollment of patients was much more heterogeneous than in the Keynote trial. And it also allowed the non-clear cell patients to participate, but those patients may not respond as well to the drug being used. And the Checkmate 914, when you deliver 2 drugs, you amplify the side effect burden, and a large fraction of patients dropped out of the therapy because they got sick for side effects. And so perhaps this is just too toxic and not a smart choice for patients that are fundamentally cancer-free, and their goal is to return to their life and not be encumbered in a large way by the therapy being delivered. So one question we certainly have is, can we be more sophisticated in how we select patients for adjuvant therapy? And I wanted to show you a trial that's not a kidney cancer trial, but it's a really, I think, a very fascinating demonstration of using a new biomarker that's emerging and becoming widely talked about called circulating tumor DNA. So this is a trial that's similar to what we were just talking about. This is in bladder cancer patients, urothelial carcinoma. It's an adjuvant trial, so patients are post-surgery, they're cancer-free, and they received a year of the atezolizumab drug or no therapy. And you can see the outcomes lines here basically are overlapping. This was a negative trial. It was judged to not show meaningful benefit for the atezolizumab. This was a large international trial, hundreds of patients in each arm, and very disappointing for the primary analysis and outcome. But part of this trial that was analyzed after the trial had been completed and reported the clinical outcome is that patients had blood drawn as part of the study to look and see if they had a positive or negative test called circulating tumor DNA. So in their blood system, did they have DNA that appeared to come from tumor? So by definition, these patients are cancer-free by imaging. So you're saying, do I have a tool that can detect this micrometastatic, this tiny bit of tumor that might be left? And so you can see the 2 dark lines, the red and the blue, are patients that had a positive ctDNA test. And those patients fared very badly. They had a very high risk of cancer recurrence. But for these patients, if you applied the atezolizumab, there was a marked difference and it improved their outcomes. So had this trial been done exclusively in this patient population, it would have been judged a positive trial and a success for atezolizumab. The patients that had no ctDNA detectable fared much better, and their overall success of staying cancer-free was markedly better than the other patients. But the atezolizumab drug for those patients did nothing at all. They're no better. So the question is, can we apply a tool that's going to let us, in a more sophisticated way, tease out who are the patients at highest risk for their disease and who will stand to benefit the most from applying an adjuvant therapy? So there is a commercially available test that can be ordered in the clinic called the Signatera ctDNA test. It's approved by Medicare and most third-party payers to be used for patients, any cancer patients. It doesn't specify the diagnosis if you're being treated with an immunotherapy drug. So this is a little schematic for what you do. It's fundamentally a blood test. So in the blood system, there's a small bit of DNA that can be collected. And most of that's coming from our normal cells. None of our cells live forever, ever. Our blood cells die, they break down, and a little bit of DNA is released in the blood. The lining cells of our blood vessels eventually die and are shed, and a little bit of DNA is in the blood. So much of it is our normal DNA. How could you tell if it's coming from tumor? Well, the first time you request the test, the company asks for a sample of tumor tissue. They sequence the DNA, and they identify what are the genetic mutations that are unique to the tumor. And then that's what they look for in a blood sample. And you can request the blood testing over and over again. And so this is a theoretical patient that would have a positive test in the setting of being diagnosed with some sort of cancer. They have surgery, the cancer is removed, and then the test goes from positive to negative. And so now you could follow that over time and see if at some future time point you have a positive finding that might herald disease recurrence. But this would place this patient ideally into a category of patients at much lower risk of their disease recurrence. This type of testing has really had very little study for kidney cancer patients. And so it's hard to know what we would use, how would we interpret the results of using the Signatera test, but we'd like to gain experience with that. And we've opened a study on our campus we're calling the PREDICT trial, where we're going to start collecting ctDNA in our patients as they go through therapy and in parallel with body imaging to gain some perspective on, do we think it has added value, and is it going to help us in the management of our patients? And so if you're in our clinical program, we may be asking you about your interest in participating in ordering ctDNA testing as part of your care if you're receiving an immunotherapy-based approach in our clinic program. And then the last minute, what I wanted to point out is that even though we have pembrolizumab and it does have a measure of success, it's imperfect. As we saw, patients still have a significant risk of disease recurrence. So how can we do better? There are studies that are ongoing looking to see if we can improve on pembrolizumab, as it's the only therapy that's shown benefit in this setting. It's a one-trick pony. So we're building on top of pembrolizumab, and there are two trials I wanted to highlight. The LIGHTSPARK-002 trial is pembrolizumab plus an oral medication called belzutifan as a two-drug cocktail versus pembrolizumab alone as the comparison. Our site participated in this trial. It's now finished enrolling patients earlier this year. So we'll be waiting to see what that study shows us in the next couple of years as results begin to mature. And then another study, and Dr. Braun actually alluded to this, the V940-004 trial, is pembrolizumab plus an investigational cancer vaccine. That's a personalized cancer vaccine based on sequencing your own tumor. That's, again, compared to just pembrolizumab alone. And the Fred Hutch will be a participating site for this study. It's going to take about 4 months or so, estimated, to go through the regulatory process to open. But later in 2024, we hope to have this trial available for patients. So what are the takeaways for the adjuvant therapy? We looked at the Keynote 564 data, which I think represents a real landmark study in the field, showing 1 year of adjuvant pembrolizumab associates with both disease-free and overall survival for the very first time for an adjuvant therapy, but only for patients with what's defined as high risk and clear cell histology. Despite the success of pembrolizumab, other trials were negative, and we know a lot of our patients are still at risk for relapse. So we're still looking out for better therapy. I told you briefly about the ctDNA as a biomarker. We want to explore that in our clinic population for kidney cancer and start using the test and gain insight into whether there's added value for using that marker. And new combination treatments are in clinical trials. We've had these on our campus. We'll have another one coming soon. So for patients that come to us later this year, we will have an option to talk about a research angle for adjuvant therapy. So thank you for your attention. And if we have a couple minutes, I can field some questions. I guess I'm at the end of my time. Let's see.
Thank you so much. Yeah, I think we're close, but I think we can just quickly address a couple of different questions. Can a cancer patient who has no evidence of disease with plans for immunotherapy get the ctDNA blood test?
It's commercially available. It can be ordered, so there's no barrier to ordering, but the insurance approval, people look at Medicare as their decision-making is usually driving other third-party reimbursement, and Medicare is based on a large trial with immunotherapy. And so the language of Medicare approval is using it in the context of immunotherapy. I don't know if it was ordered, it would be run by the company. I'm not sure what that would happen in terms of reimbursement. The company does have lovely information on their webpage. You can call them and try and get more information on whether there would be a cost. So if you have interest, I encourage you to reach out. The name of the company is Natera, Natera.
Great. Thank you so much. Thank you for that fantastic talk, Dr. Tykodi. Our next speaker is Ray Palko, and I'm very excited to hear his talk. We get so many questions from our patients about nutritional support in the setting of kidney cancer or kidney cancer treatment. So thank you so much, Ray, for joining us today.
You're welcome. Thank you, Dr. Gore, for having me and giving me y'all just a moment as I try to get my slides figured out, how to show them in the view mode. I struggle sometimes on Zoom with this slideshow. There we go. From beginning. We got it. All right. Good afternoon, everybody. Thanks for hanging around towards the end here. As Dr. Gore introduced me, my name is Ray Palko. I am a registered dietitian and board certified specialist in oncology nutrition here at the Hutch, and looking forward to talking to y'all today a little bit about nutritional supplementation. My disclosures are very minimal. I'm an employee here at Fred Hutchinson Cancer Center, and I receive no compensation, financial or otherwise, from any supplement manufacturers. Our outline is here. I'm going to go a little bit heavier in the background section because it'll be really important to give a lot of background about different supplements. Then we'll talk about supplements and cancer risk, macronutrients, micronutrients, fiber, and probiotics. And before I start, I'm just going to ask all the attendees, especially if you have your pen and paper handy, if you're taking notes, this will be great. As a little thought exercise, I want everyone to consider, do you think you will walk away from my presentation wanting to take more supplements or less supplements? So write down your answer to that, and it'll be interesting for you to reflect on your answer after the fact. So dietary supplements are intended to add to or supplement the diet, and they are different from conventional foods. Common supplement categories include vitamins, minerals, botanicals and herbs, botanical compounds, amino acids, and live microbials. Some important things for you to know about supplements on the label. Sorry, I had to minimize the speaker screen that was in front of my slides. On the label, the manufacturer will suggest to you a serving size, but your healthcare provider might decide that a different amount is right for you. So you never want to grab a supplement and just think right off the bat, follow what the bottle says. In terms of effectiveness, some supplements can improve health and manage certain conditions. Two examples would be calcium and vitamin D to arrest bone loss, or folic acid to reduce the risk of certain birth defects. Many supplements need more study to determine if they have value, and I bolded this point for a reason. It's very important. The Food and Drug Administration does not determine whether supplements are effective before they are marketed. We also want to be thinking about potential of safety and risk and about quality. Regarding safety and risk, supplements can interact with some medications in ways that can be problematic. For example, vitamin K can decrease the effectiveness of a blood clotting drug. Antioxidant supplements may reduce the effectiveness of certain cancer therapies. I said chemotherapy's on that, but truly chemotherapy, immunotherapy, radiation, all of these we have concerns about how certain high degree of supplementation could have an interference. And regarding quality, if you are taking supplements, it's best to seek products with independent third-party testing. This does not guarantee to you safety or effectiveness, but it indicates proper manufacturing, accuracy of ingredients listed on labels, and absence of harmful levels of contaminants. So these three graphics that we have here, NSF, USP, and CL, these are three third-party verifications that you would want to be looking on your supplements and seeing if one of these is listed. Then you have a higher degree of confidence that what you purchased, what the bottle says, actually contains that. Okay. Also important to know, we do want to keep in mind this first bullet here. The term natural does not always mean safe. I know I hear a lot from our patients when we talk. They say, well, isn't there a way I can do it naturally? No disrespect intended to anyone involved, but this is really important that we recognize the fact that cancer is a natural occurrence in our world. So that means we don't want to treat the term natural like it's, like I said, like it's safe or like it's something we've got to chase after. Before taking any supplements, you want to ask yourself and your doctor a few key questions. What are the potential benefits? Are there safety risks? What is the proper dose? How, when, and for how long should I be taking this? And again, important to note, medicines must be approved by the Food and Drug Administration before they can be sold and marketed, but supplements do not require this approval. On this slide here, the top banner, this is the website address where any of you interested can get yourself a copy of this dietary supplement and medicine record. This is coming from the National Institutes of Health. And I would say for anybody that's taking any supplements, that if I ask you, why do you take this? And you say, I don't know, I think it would be a really good idea to audit your supplement drawer and to go through this record and list everything out and consider, okay, is there a benefit to me in taking this supplement or not? Now, when we think about supplements and our overall cancer risk, are they good to lower cancer risk? Are they ineffective? Well, from the American Institute for Cancer Research, they have one of their 10 recommendations in lowering cancer risk is to not use supplements for cancer prevention. Rather, the AICR recommends we meet our nutritional needs through diet alone, and it is advised against the use of any supplements for specific protection against a specific type of cancer. That part of the guideline is informed some other cancer types, prostate and lung cancers. Clinical trials were run to assess if micronutrient supplementation could be making the treatment more effective. For lung cancer, it was vitamin A, and in prostate cancer, I believe it was the SELECT trial where they were giving the gentleman selenium and vitamin E. Both of those trials were halted as we saw disease progressing with these additional supplements. Now let's talk a little bit about our macronutrients. Macronutrients are the ones that we need in a relatively large amount, as indicated by the name macro, and they're what provides us our energy. Macros provide energy, and they include protein, carbohydrates, and fat. Just take a quick peek at the graphic over here. I really like this. I borrowed it from Cedars-Sinai in Los Angeles. The thing I like about this graphic, different from a lot of other discussions, is that you see the overlaps. So you're seeing there that you've got some beans, lentils, and legumes giving you carbs and protein. You're seeing that dairy, eggs, and some meats can give you protein and fat. So I think it's just a nice, more well-rounded vision of this to show that nothing's absolute. And when we choose a whole food, we can get a ton of different benefits and properties versus choosing a supplement where it might be something isolated. Now, macronutrient supplementation, this is only indicated if you cannot eat enough food to maintain your weight and support your regular physical activities. Macronutrient supplement options include two main streams: liquid nutrition shakes and whole foods-based smoothies. This slide just gives you a little bit of a breakdown on the difference between a liquid nutrition shake and, a liquid nutrition supplement and the protein shake. So these are two really different things, and this is one spot that me and my clinical colleagues spend a lot of time walking people through what's the right supplement for them if they want one. The liquid nutrition supplements, basically, if you're struggling to eat enough and you're losing a lot of weight, that's where you want to head to that stream. The protein shakes may often just be for, sometimes maybe during cancer treatment, we can eat enough, but meats and eggs, they're just not really palatable. So maybe we need a little extra protein. That would be that example. Now, as far as supplementing other individual macronutrients, carbohydrate and fat supplementation is rarely ever recommended. If you need to supplement those two, very likely you need to supplement protein, and you're going for the full liquid nutrition shakes. Protein supplementation, however, that's often necessary to maintain lean body mass during cancer treatments. Protein supplement may also be recommended for very active individuals as they are breaking down their lean body mass. We need to build it back up. Or for elderly individuals, as we get into mid-60s, definitely in our 70s, our body has a reduced capacity to build and maintain that lean muscle mass. So for some of the older folks on the call, it may be a benefit to have a little extra supplemental protein. And this comes in the forms of either a protein powder or a protein shake. Your whole foods sources of protein are going to include some things that are high protein, some are medium. Your high protein foods, there's a lot of options to meet this, whether you're a vegan or a vegetarian or omnivorous. You've got red meat, important note, we want to limit that to 12 to 18 ounces per week at most. That is due to the fact that if we're having excess red meats or really any high amount of processed meat in our diet, will elevate our colorectal cancer risk. So it's okay to eat red meat, but just keep it a little lighter. Poultry, fish, seafood, eggs, and dairy are all great protein sources. And in the plant world, beans, lentils, and legumes, including soy products, and nuts and seeds are high protein sources. And then we will get a medium protein source out of whole grains and some of our vegetables as well. Okay, now let's shift over to the micros. We talked about the macros, these big high volume nutrients. The micronutrients are ones we need in relatively small amounts. So that includes both our vitamins and minerals and some of the key terminology we want to be considering here. DV, that stands for daily value, and that can help consumers determine the level of various nutrients in relation to their approximate requirement for it. So the DV is pretty much based off of the RDA, which means the average amount of a nutrient that average people need to not develop a deficiency. And then we also definitely want to be thinking about the UL. That is the tolerable upper intake level. And this is the highest amount of a nutrient that you can take that is not likely to pose adverse health events. A really important caution here, earlier I spoke about those labels and how, that's a manufacturer telling you how much to take. But when you look at the UL, I go through the grocery store and I look at different supplements and I see multiple things for sale that an individual dose listed on the bottle is higher than the UL. To me, that's problematic. However, due to the legislation around supplement governance in our country, it is allowed per the Dietary Health Education and Supplement Act of 1994. So maybe sometime in this millennium, we'll get some new laws about supplements. Right, let's see. Okay, now individual micronutrient supplementation. This is recommended if your diet is deficient in any specific micronutrient or if there is a blood deficiency of any specific micronutrient. And there is no value to supplementing micronutrients more than the daily value, and there are potential negative consequences that can occur. Remember that from some of those earlier slides, and we're talking about the potential to interfere with cancer treatments. Now, a multivitamin or a multimineral, these go under other names like One A Day, or people will commonly float a manufacturer name. So I took a Centrum. Multivitamins and multiminerals, they can help protect against vitamin and mineral deficiencies if we're eating lower amounts of food due to cancer treatment. So this can be a really good option if we know that we're eating less overall. It's kind of like your insurance policy. These are also very valuable if we have a poor diet quality. If we're struggling to eat enough of the fruits and vegetables and lean proteins that are recommended, this can be a nice bridge, but we do always want to try to help people improve diet quality. And a nice study that was published recently showed some benefits on cognition in older adults taking a daily multivitamin. The mean age was about 73 years old. So me at 30 years below that, I already take my multivitamin to make sure I keep my cognition. And when you're selecting a multivitamin and mineral, search for a product that's as close to 100% of the daily value as possible. This is a great example that I found somewhere online here showing something that's mostly 100%. That's kind of where we want to hit. You don't need to go way above that. And if it's a lot below that, it's not really giving you any help. All right. What are our whole foods, vitamin and mineral sources? All whole foods. This is a great time for me to point out when I say whole foods to y'all, I'm delineating two types of food. Whole foods, these are things that look like they have a home in nature when they're on your plate. If you're eating broccoli, it looks like a tree. You know that came from the earth. Versus processed foods, which arrive on our plates in a shape, size, and or color that doesn't occur in the natural world. Any type of whole food is going to be rich in different vitamins and minerals. Red meat, poultry, and fish give us iron and B vitamins. Dairy provides calcium and potassium. Fruits and vegetables provide vitamins A and C. Nuts and seeds provide iron, copper, zinc, and B vitamins. And this is really just a very quick cursory list. I didn't do any research or look at anything to make these 4 bullets, just pulled it off the top of my head. Numerous other micronutrients are in these and other foods. So a diverse and balanced diet can often provide all needed vitamins and minerals in adequate amounts. Now, we only have one little exception here, and that's vitamin D. There is not enough vitamin D in our food supply to realistically provide normal levels in our bodies. People often think about sunshine for vitamin D, but to get enough sun exposure to make significant vitamin D, you would then be putting yourself at risk of skin or melanoma cancers. So this is the one spot that most people probably ought to be supplementing with, would be some vitamin D. Okay, this slide here about fiber supplements, my apologies to everyone. It is extremely busy. I really should have taken time to pare it down a little bit more. But the point that I want to get across to you here about fiber supplementations, they're broken out into 4 meaningful designations. Think about why are you taking a fiber supplement. If you feel that you just can't eat enough of these whole plant foods in your diet, I think that any choice of a fiber supplement will be a helpful thing as you work on improving your diet quality and eating more fiber-rich foods. But if it is a constipation issue, you want to have the first bullet or the last bullet. Something like some wheat bran or the product psyllium, psyllium is a food substance. Metamucil is the most common brand name for psyllium. These are the 2 that actually help you with laxation. The others will definitely have some degree of benefits in the body, but they don't have that laxative effect. And what are your whole foods fiber sources? All type of plants. All foods of plant origin will have some amount of dietary fiber, and the closer it looks like that thing you can see in nature, the more fiber it has. See, again, there's the little trees, the broccoli. With a balanced diet and 3 meals per day, looking similar to this, with more plants than animals on the plate, you will likely be eating adequate fiber. Probiotics. Probiotics defined, these are live microorganisms that are intended to have health benefits when consumed or applied to the body. We find them in yogurt and other fermented food and dietary supplements. Dr. Tykodi actually was the influence on me getting this slide into the presentation. There's a lot of interest in probiotics that is growing.
Sorry, I didn't know my foot was under it. I'm sorry.
Especially considering some of the current research.
That far out.
Sorry for that. Let's start that sentence over. Had a little bit of static in there. Interest in probiotics is growing, especially considering current research into probiotics increasing the efficacy of immunotherapy. This is a really, really exciting research space, but while promising, we don't encourage anyone to try to self-replicate a clinical trial on your own. So that's a really important thing to note. And to aid in the diversity of your gut microbiome, we recommend a balanced diet, including a wide variety of plant foods. Like the prior pictures we saw, those plates, that actually probably has a greater effect for your gut microbiome and your good healthy bacteria, is getting the prebiotic fiber out of the plant foods to fuel that good bacteria, rather than just adding extra probiotic bacteria on top. Got another very busy slide for y'all, but there's some good stuff to tease out of it here. Top bullet, we do have some evidence that probiotics may be helpful for acute diarrhea, antibiotic-associated diarrhea, and atopic eczema. Some probiotic formulations have shown promise in research, but strong scientific evidence to support other uses of probiotics for most conditions is lacking. This third bullet point here, the major sort of takeaways I want to see here, risk of serious side effects may be greater in people who have underlying health conditions. Cases of severe or fatal infections have been reported in premature infants who are giving probiotics. Similarly, with a heavy cancer burden and undergoing a lot of treatments, our small intestines can start to get a little bit weak and we don't have that strong barrier we want there. And there is a case report of a patient with a blood cancer undergoing stem cell transplant who became septic with bacteria from yogurt into their bloodstream from just eating way too much when they were not eating anything else. So again, it's a caution space of probiotics. It's got the health halo. Everybody says, oh, probiotics good. If we're less than totally healthy, we got to be real careful about it. This fourth bullet's great too. Different from person to person, the effects of a probiotic. So this is another one where, you know, if your buddy that you play tennis with or your girlfriend in the knitting group says, oh, I took this probiotic and everything's great, you don't necessarily want to take their anecdotal advice and put it into your body. So if you're considering a probiotic supplement, talk with a healthcare provider first. Please do not replace scientifically proven treatment with any unproven product or practice. And your whole food sources of probiotics are going to include different fermented foods. So yogurt, kefir, and other cultured dairy foods, sauerkraut, kimchi, and other fermented vegetables. Okay, we are getting wrapped up here. I've got my resource slide for everyone. If you really have a heavy interest in dietary supplements and trying to learn more about these are 3 great resources you can utilize. The National Institutes of Health, the Office of Dietary Supplements, is going to give you all type of info about any vitamin or mineral and what's the UL, what's the RDA, etc. That's great, free to access for everyone. Memorial Sloan Kettering, big cancer center in New York City. They have a great website and smartphone app. It's called About Herbs. And they'll give you great breakdowns of common supplements and looking at the research and if there's anything you need to worry about before taking. So that's a great thing you can use. And then the last one has all the information, but it does require a paid subscription, and that's NatMed. I do not know what the subscription costs. I get it for free through a professional association, so I'm not sure. All right. That takes us to the end, so I'm happy to field any questions before we have our next speaker coming along. Maybe I should stop the share.
I was going to say thank you so much, Ray, for that terrific talk.
You're welcome.
I don't see any questions in the chat. You know, when you meet with individuals who are interested in just learning in general what, you know, they can do to improve their nutritional outcomes with cancer, are there just like 2 or 3 bullet points? Obviously, oversupplementation is a problem. Eating well is a good thing. Are those sort of the main take homes?
Yeah, you know, I would think be sure to pay mind to your protein intake. That is such an essential and valuable nutrient throughout so many different stages of our life that it's important to recognize that we have these whole lives outside of cancer, right? So you could be one of my parents in their 70s and you're going to need the extra protein because you're in your 70s, let alone the cancer. Or I've seen some younger, super fit folk that I'm like, hey, you need more protein for the way you're working out, not even for your treatment. So pay in mind to how we eat with adequate protein coming in, always get fruits and vegetables in, and choose the ones that are grown as close to your home as you can. I think that's and move your body around a little bit too. And that's going to look different for everybody. If you're that high level of exerciser, you might still be getting out and jogging. But if you're more like my parents that, you know, don't do as much physical activity, don't spend your days only moving between the couch and the clinic. It's really vital that we try to keep up with our normal levels of movement. And if that's, yeah, keeping up with our normal levels of movement. I'll stop there. I could talk to everybody all day if you want to extend the time.
Yeah, one late breaking question. Any thoughts on curcumin?
Oh yeah, thoughts on curcumin. So I would definitely encourage anyone especially if you like the flavor, I would encourage cooking with the powdered spice of turmeric, using the root, putting that into things. The curcumin itself, that's one of the biologically active compounds in turmeric. And I don't have a hard cautionary worry in this population, but in the breast cancer population, we actually have some research experiments that some of the most commonly used chemotherapies, their action is inhibited by curcumin. So we really want to be cautious there. So I would say that, if you're outside of any degree of treatment and you want to be even in treatment, using it in a culinary sense, absolutely. But a concentrated supplement in treatment, I would advise against. And even outside, I just don't know that all the benefits are there. And I saw one about graviola. I can't remember everything, but I have a red flag in my head. But the red flag might not be needed. So I'm seeing if I can look at about herbs real quick, if I can get to that before you have to move on. Where do I have them?
Right. I think it's a good call to action that when we wrap up here at 1, maybe we should all get outside and move our feet a little bit.
Yeah, especially as we have a decent weather right now. I'm struggling to find the database to look up any info on graviola.
No worries.
There may be a red flag there. Anybody, hey, y'all take a look on, everybody has the website now. Go look on About Herbs. I know they talk about graviola. So take a peek there and see what they have to say. I trust whatever they're saying.
Thanks so much, Ray.
Yeah, of course.
Sorry. As we navigate to the end of our symposium, it's my pleasure to introduce Megan Little, who's our Director of Philanthropic Gifts at the Fred Hutch Cancer Center, and she's going to talk about the importance of philanthropy as we consider kidney cancer care, kidney cancer research, and our local community.
Well, thank you, Drs. Tykodi and Gore, for the invitation to be here today and to also learn as well as share ways that folks can get involved. Can you see my presentation?
Not yet.
Let's see that I did that correctly. How about now?
Yes, but you do need to the other way. Just switch. Yeah, if you go to display settings. Okay.
I am not able to see that part. I apologize.
You can just click slideshow.
Mm-hmm.
And then display settings. Right above it, display settings.
I'm just not seeing it because there's a bar that's showing.
Okay.
Can you tell me where to click if you see it on your end?
Yeah, so it's right next to show taskbar. I don't know if you can see that.
I can, yeah, I can't see it below the audio. This is a...
Do you want me to share your slides for you?
Yes, please do that.
Okay.
I'm now trying to escape from my presentation, and I'm sorry for those who are still on. I hope I didn't lose too many audience members. Well, I'll just start by, yes, thank you. And if you could go to the next slide. I wanted to start by sharing a little bit about Fred Hutch and why this organization is so special. And for those who aren't familiar, Fred Hutch is a leader in cancer and infectious disease research and care. Our focus on innovation goes back to our roots in the 1970s when Fred Hutch led the development of bone marrow transplantation to treat cancer and other diseases. Since then, more than 1.5 million people have received this powerful treatment. Bone marrow transplant provided the first definitive evidence that it's possible to harness the body's own immune system to fight disease and help spark a revolutionary new field of cancer treatment now known as immunotherapy. For decades, Fred Hutch has continued to push the leading edge of immunotherapy, and we also work at the front lines of infectious disease. And that includes leading the HIV vaccine trials network, the largest publicly funded international collaboration conducting clinical trials of HIV vaccines. In fact, our longstanding work with HIV Vaccine Trials Network that perfectly positioned us to step up when COVID arrived in communities. Fred Hutch became the coordinating body for COVID vaccine trials, helping to bring safe and effective vaccines to the world. And now today, we remain a leader in COVID-19 vaccine as well as disease research. Next slide, please. 2 years ago, we restructured our organization and united Seattle Cancer Care Alliance and Fred Hutch. We also strengthened our relationship with UW Medicine and Fred Hutch and serve now as UW Medicine's cancer program. What's so important about this is we are now better able to bring research and patient care closer together. Every day, more than 5,700 clinicians, scientists, and staff work together to advance innovative research and compassionate care to a number of patients. Actually, we're now at about 53,000 patients per year. Findings made in our laboratories can get to patients more quickly, and in turn, we can bring patient experiences back to our labs to inform our research initiatives. We're committed to working on all aspects of cancer, including prevention, diagnosis, and treating the whole patient while working to ensure equal access to care and equitable outcomes for everyone. I'm so pleased that together we heard about the advances advocates and supporters like you made possible. Thank you. And if you could just go 2 slides over. One more, please. Ways to get involved. You can consider participating in a health study. Clinical trials and volunteer studies are a vital and critical component of disease research. Could you go back 1 slide, please? You can also volunteer. We are so grateful to those who choose to volunteer in a variety of ways, including offering peer mentor support, providing wayfinding information and social support for oncology patients and families, and escorting patients to floors and appointments as needed. You can also consider participating in an event. We have our big Obliteride coming up in a couple of weeks, and obviously today's symposium is another wonderful way for folks to participate, advocate, and learn. Main reason why I'm here today is considering support through philanthropy. You can consider making a gift to support renal cancer research or another priority of your choice. And if you could go to the next slide. Support provides us with funding we need to plan for the future, follow the science where it leads us, and be ready to drive new discoveries forward as quickly as we can. Gifts of all sizes and types matter, and there are many ways that you can give to fit your lifestyle. We are so grateful to people who have generously donated once or many times, have included us in their will or estate plan, or who have used other options such as exploring how giving through donor-advised funds or transferring required minimum distributions from their retirement accounts can provide tax advantages. Once again, thank you. The last slide has my contact information. Our philanthropy team welcomes the opportunity to partner with you. Together, we can shape a gift that has the impact you wish on the disease you care about most. Feel free to contact me to learn more about ways to support some of the promising research we heard about today, or questions you might have regarding philanthropy or other ways to get involved in Fred Hutch. Please don't contact me if you are looking to receive presentation skills for a virtual event. And with that, I will hand off to our co-chairs, Drs. Tykodi and John Gore.
Thank you so much, Megan. I really appreciate you spending time with us and educating us. And I want to thank all of our speakers and our participants on the symposium. You know, every year it seems like the number in the participant tab goes up, and we really appreciate everyone making time on a Saturday to join us and learn about kidney cancer and how it pertains to them in their own care. Dr. Tykodi, do you have any final words?
Thank you, John. And yeah, thanks from me too to all of our speakers and participants today. Before we go, I just wanted to recognize Ritu Shriyan. Ritu, I don't know if you can turn your camera on. Ritu is the program coordinator that actually brings this program to life. Ritu, you've done this for 3 years now, I think. All the background planning and communication and coordination that has to happen. So we wouldn't have a program without everything that Ritu has done up to this point. So thank you for all your contributions today. And one of our goals is just to help people network and link. We had outside groups that give you a national perspective on support, on advocacy. But if you are looking to do something closer to home, Megan is a great first call for any sort of volunteer connection, anything that you're interested in. I've had patients reach out in years past that were curious to learn more about the research efforts and tour research labs on campus doing kidney cancer work. So all of that is possible. And lastly, a reminder that we mentioned at the beginning, and we'll mention again now, please, please, please fill out the survey. We love to hear what the audience thought. What things do you want to hear next year? What topics, speakers, what format, if you have a strong opinion about virtual versus in-person versus hybrid. We look at that a few weeks after these events, and we consider that for next year's planning. As John said, this is our 10th year, our 9th program. We had a COVID year where we went dark. We started in 2015, and we expect this to be an annual summer program going on so long as Ritu is around to help us make this happen. So we definitely will consider comments as we start thinking forward for what 2025 will look like. So I appreciate everyone giving us half of your Saturday in the sunny season for Seattle. That's a big ask. So really appreciate everyone's attention. And thanks everybody for being here today.